webinar. We are currently waiting for one of our senior professors to log in so that we may kickstart this particular symposium. This afternoon, you will be facilitated and moderated by Professor Dalton Pamalwa and myself, Dr. Ann Beatrice Kihara, and we will have rapporteurs who will be with us and taking notes, and that is Dr. Samuel Kagema and Dr. Zainab Dida. We want to extend a hearty welcome to each one of you. I can see we're already having 444 attendees, and that is not including the panelists who so far we have 12 who have logged in from far and wide. I want to give a special recognition to Francis Githai, who's actually with us from the UK, and having been one of us, is still with us. So we really want to appreciate each one of you. So I will hand over to Professor Dalton Pamalwa, who will be coordinating the first part of this afternoon, and then I will take over from him. Welcome, Professor Dalton Pamalwa.
Thank you very much, Dr. Kihara. It's a privilege to facilitate this symposium. As Dr. Kihara has mentioned, we just have one of our colleagues in a minute who will join, and then we'll be underway. Thank you. Colleagues, this afternoon we have various sessions that we shall go through with speakers that I'll introduce as we go by. Each time we have a speaker, I'll make a brief introduction. And right now, to start us off, is Professor Omondi Ogutu. Professor Omondi Ogutu is a very senior obstetrician gynecologist, teacher and mentor to many people in the audience. He's a current chair of the Department of Obstetrics and Gynecology at the University of Nairobi. He has a vast experience in fetal maternal medicine. And I'd like to welcome you, Professor, to give brief remarks as we start this symposium. Welcome, Professor Omondi.
Thank you, Professor Pamalwa, for the gracious introduction and welcome. And welcome all colleagues and participants in this important symposia, which we are going to hold for the next 3 days. This is a collaboration between the Departments of Obs and Gynae at the University of Nairobi, Departments of Pediatrics and Child Health, and also with the Kenyatta National Hospital, especially through their Center for Research and Training, which is being headed by Dr. Kinuthia. I hope I've referred to your docket correctly, but if not correctly, please forgive me. The principal, of whom you have just been having some session with, has sent his greetings. Remember, principal is Professor Machoki, who is also an obstetrician gynecologist like us, and he's also very keen in this. This session is going to be quite interesting, and I would like each and every one of us to really look at the sessions which are going to be covered. The sessions are really interesting. I'm sorry if some of you would want to log in and thereafter log out, because once you log in, you'll realize that there'll be a lot of education material which has been put forward. Several faculty members, both from within the country and also from us outflank countries like from the UK. We have one of our colleagues from the UK who is going to give 2 presentations, and is also one of the faculty members now at the Department of Obstetrics and Gynecology. This session is a continuation of the session we had last month, which was looking at the issues related to adolescent health. Now we are coming to look at the perinatal health, and more so also covering the maternal issues, which has got a direct influence in the perinatal health. And that's why these sessions are all intertwined, and it has got a multidisciplinary approach. And each and every person has been tapped depending on his area or specialty. And we are therefore going to have quite an interesting presentation over the periods. And I don't want to spend more time in trying to elucidate what's going to happen, but I would really want Dr. Pamalwa to take over so that he can be able to chair and steer the sessions, which will go on up to 5 p.m. and then each day until Friday. Welcome everybody, and let's start the medical sessions to start. Thank you, Professor Pamalwa. And I must not forget congratulating Dr. Ann Kihara, who is one of the key organizers of the session. For those who don't know, Dr. Kihara is a senior member of the Department of Obs and Gynae. And in the tradition of the Kenyatta National Hospital Consultant Fraternity, she's the consultant of the week this week. And it's usually a big honor. Let's all honor Dr. Kihara for that achievement and recognition given by the peers. Take over, Professor Pamalwa, and let the sessions begin. Thank you.
Thank you. Thank you indeed, Professor Ogutu. And thank you for beginning the introduction of our first speaker, who is Dr. Kihara. As you've been told, she's senior lecturer in the Department of Obstetrics Gynecology. She's also, she received training at the University of Nairobi and the University of Manitoba in Canada. And she's a past president of COGS and president of AFOG. Professor Mondi, kindly mute. So Dr. Kihara will start us off, and she will be giving us the rationale for the symposium. I hope that Secretariat, we can have Dr. Kihara's slides up so that she can start taking us to the session. Welcome, Dr. Kihara. Dr. Kihara, the floor is yours. If you could have start off, please.
But eventually delivers a stillbirth. Or the baby dies within the first week of birth. This is what we call perinatal deaths. They're often unnamed, uncounted, and unknown. Globally, 2 million babies are born stillbirths. This is data from 2019. 2.4 million die in the first month, with 30% on this birth date, and 75% in the first week of life. Majority, unfortunately, happening in low middle income countries, and in 80%, it is preventable. Stillbirths and early neonatal deaths arise from poor maternal health, inadequate care during pregnancy and delivery, failure to provide life-saving interventions, simple measures like corticosteroids, provision of magnesium sulfate, antibiotics, or even KMC. Poor hygiene practices during delivery and the first critical hours after birth, and lack of immediate newborn care, which includes identifying the sick neonate. Several factors, such as the woman's status in society, their nutrition, the timing of conception, childbearing, too often, too soon, short spacing, and harmful practices such as teenage pregnancies, gender-based violence, inadequate cord care, letting the baby stay damp or wet and cold, the discarding of colostrum as opposed to giving to the baby, and even pre-lacteal feeding. Deeply rooted cultural issues still affecting social and behavioral practices. And there's failure for us to recognize the need for a life course approach and continuum of care using the tripartite address the mother, the newborn, and the health system. Global strategy exists for women's, child, and adolescent health in countries committed to improving the health of women, children, and adolescents via transformative multi-sectoral action to accelerate coverage of these interventions, reduce gender and equity gaps, and improve the quality of services in the continuum of care. Kenya has certainly made positive strides in reduction of the under 5 and infant deaths, but has not been so promising in maternal or perinatal health. The pandemic indirectly has disrupted all our lives at all fronts, but particularly in address to this issue we're tackling, the health and health system. The socioeconomics and social livelihoods have actually dented women's attendance to clinics for both care and delivery. Unfortunately, those hardest hit are even those in more vulnerable situations. That is, urban informal, rural populace, adolescents, persons living with disability, persons living with HIV. We need to reinvest in maternal, perinatal, neonatal, child, and adolescent health. Please note, I have added the perinate in between the maternal and neonate. SDGs are not far, they're less than a decade away, and we keep saying no one should be left behind. Neonatal mortality rate for Kenya was 21 deaths per 1,000 and has fallen gradually since the early years at 38.6 per 1,000 in the 70s to where we are. We need to rethink our frontline providers are not the gynecologists, but the midwives. Where is their training and education to make sure where we don't have a pediatrician, where we don't have an obstetrician, they're armed to save more lives? Ladies and gentlemen, we are asking, and even through this symposium, are we really answering the right research questions? Are they getting answered? Or is there failure to translate evidence into action? Or are there interventions we are yet to provide in our Kenyan local context? Or is the persistence of iniquity and inequalities in service delivery still being carried on? Or are we just not being socially accountable? During this symposium, we have 3 main objectives. Why should we focus on perinatal health? The life course approach, and moving the pin of survival in perinatal health. Topics are varied from epidemiology to interventions, to addressing maternal issues, to addressing perinatal issues, and to address even when there's a stillbirth, what is the pathologist saying? But we will not run away from accountability. And this is where the civil society and communities that consume our services are beginning to also ask harder questions. At this point, I wish to acknowledge the committee that has put this symposium together, recognizing the Kenyatta National Hospital Pediatric and Obstetric Unit, the University of Nairobi Pediatric and Obstetric Unit, the ICT team that keeps on giving us the KNH-UoN webinars, and I must mention particularly the help I have been given by Dr. Kinuthia and his team, the presenters who will be presenting, the moderators and the rapporteurs. Kudos to you all. To all the participants who have been drawn from various places, nationally, regionally, and globally, the Ministry of Health, donors online, partners and implementers of care, the student fraternity, the civil society and communities, we appreciate each of you for joining us, and we hope you will remain throughout for the next 3 afternoons to share, learn, and exchange. enriching this symposium. There will be CPD and certifications that will be awarded. So I want to welcome each one of you. Let us focus on the mother and the perinate and the system in which care is provided. Thank you.
Thank you very much, Dr. Kihara. Thank you for challenging us and also encouraging us and focusing us. Thanks. Now we'll move on to next speaker, Professor Moses Obimbo. Professor Obimbo, he's the current chair, Department of Human Anatomy, University of Nairobi. He's also the Secretary General of COGS, the Kenya Obstetricians and Gynecological Societies. He's received postdoc fellowship from University of California, San Francisco. And I know he has been doing a lot of work in a placental morphology. So he's going to talk to us this afternoon on the place of placental morphology in perinatal health. Welcome, Professor Obimbo.
Thank you very much, Professor Dalton Pamalwa. Thank you, the organizers of this session, and thank you very much for the invitation. I'm going to talk about the ultrastructural features of preterm placenta from HIV-positive women on antiretrovirals. This just to contextualize on the title that I was given to talk on. So I went just specific to show the importance of the placenta in ensuring fetal health. So this work was done over a couple of years and with help from different people from Kenya and from the United States. So I'll start with this modified song on placenta that really summarizes the importance of placenta in human life. We know that during early development, when the sperm and the oocyte fuse, and then there's a conceptus. In the initial stages of formation, we have the zygote, then the morula, and then after the morula, we have the blastocyst, and then some cells, due to different signatures, go on the outer part of the forming structure, and will eventually form the trophectoderm and the fetal membranes of the placenta, whereas the other structures will then result in formation of the embryoblast that will form the embryo. So for 9 months, the placenta is able to nourish the fetus, provide all the needs that are needed by the developing fetus. And after that, it reaches the senescence stage where it actually is no longer functional. On the other side, the embryoblast can go on for 90 years. So it means there's a lot that we can learn from placenta that has a 9-month lifespan. And the signatures embedded within the placenta can actually be, seen in the embryo. So this has been a neglected organ that I think a lot of interest has to develop in it so that we can learn as much as possible from it. So these are some of the photos of images that we took during our course of studies. So we know, as I've mentioned, that the placenta is very important in the exchange.
Just to let you know, this on my side, I didn't see slides move, just in case you have moved them.
Okay, I've moved them. Let me see. I'll just end the show. Just to make sure that I move them.
And now it has moved.
Are you able to see that?
Yes, now it's moving.
Great, let me just have it that way. Yes, so on the placenta, we know that it's very important in the exchange of substance between the mother and the fetus. And the cells that line the placenta on the outer surface are the syncytial trophoblasts, which form the interface between the maternal blood and the fetal blood. The only separation between the two is the fetal endothelium and the syncytial trophoblast. So for this exchange to take place, it ensures that the mother's health is maintained and also ensures that the fetal growth and development is maintained. Otherwise, if this is affected, then we have maldevelopment of both the fetus and mother is at risk of pregnancy complications. On the surface of this cell called the syncytial trophoblast, the brush border or the macrovilli, which facilitate the functions and also play a very important role in the so-called mechanotransduction, where the maternal blood has to reach a certain pressure to allow for feasible exchange between the two individuals. It also means that the cells are exposed to multiple pathogens in the circulation and therefore at risk of impairment and at risk of impaired functions as well. So on the preterm birth, we know this is a very big burden, especially in our setup, and the cost of preterm birth is just not at individual level, but is also at systemic level. At individual level, it affects the performance of that individual throughout life. It could lead to mortality. At a systemic level, and the healthcare costs, of course, is enhanced. And this, we have individuals who probably are not able to be very productive in their future lives. So we face the greatest burden of preterm birth in low and middle income countries because we cannot afford the facilities to take care of the newborns as opposed to the West. So this subject is of interest and we have to explore it much more. And HIV and how it's related to the preterm birth, we know that HIV and antiretroviral treatment are independent risk factors for adverse pregnancy outcomes. Various studies have shown and implicated HIV in adverse pregnancy outcomes like stillbirth, small for gestational age, preeclampsia, preterm birth, and so forth. And there have been studies on various regimens of antiretrovirals like protease inhibitors, non-nucleoside protease inhibitors, and so forth. And they have actually been shown that they could be causing the risk of preterm birth. So we do not know the mechanism by which either HIV or antiretrovirals are associated with a preterm birth, but this could be through dysfunction of the placenta. So in labor process, there are basically common pathways, and these basic common pathways involve inflammation that result in contraction and changes in the cervix, and then leads to the rupture of membranes. And these changes take place at both the uterine level and the fetal placental units. So in our work, we basically focused at this particular point and wanted to understand how does the fetal placental unit, how is it affected with HIV and antivirals, and do these molecules cause placental damage? And if they do, what are these changes? And these changes, could they explain the occurrence of preterm birth, preterm labor, and then preterm birth in this cohort of patients? So we did our first aim where we basically compared the microscopic, and morphometric features of placenta in deliveries amongst HIV seropositive and seronegative patients. And here we basically examined the cord, the parenchyma, and the placenta. We went on to do light microscopy examination, and we also did some histology and histomorphometry work. And generally, we got this paper published, can be checked out. And generally, we found that the placenta from women in preterm birth had less weight, had a marginal cord insertion, and they had reduced thickness. At histological level, what we found were features of the syncytium delaminating from its normal morphology. There are quite a number of red blood cells that would be found within the intervillar spaces. And then we had hypervascularization of the terminal villi, showing features of hypoxia within this placenta. And more importantly, we had extensive fibril deposit laying within the placenta tissue. So at this particular point, we already started to see significantly placenta from preterm birth of patients with HIV and on treatment had features that could be suggestive of impaired placental function. So we went on to look at the surface morphology of the placenta in HIV positive women. And we studied this using scanning electron microscopy, which has been described as a standard tool to explore the morphological characteristics of any cell. And so we basically collected our samples from Pumwani and Kenyatta National Hospital. And we had about 160 patients and from HIV positive with preterm birth on the antiretrovirals, and HIV negative term, and the other in between. So we did this work with the normal procedure of staining for scanning electron microscopy, which included washing phosphate buffer solution to sputter coating, and then we did visualization using scanning electron microscope of the Zeiss Malin. Did this at at Stellenbosch University. So generally, in terms of the gestational age ranges, the preterm birth were basically at 34 weeks, the term were 39 weeks. Those with preterm deliveries were older than those with term deliveries. Then 36 patients had a cesarean section for the preterm birth and 28 had cesarean section for the term deliveries. So, and in summary of the findings for placental HIV positive women on antiretrovirals showed widespread damage of the syncytium, and the syncytium were basically showed features of shriveling, and they were shrunken, and then they lost congruency at the terminal buds of the placental terminal villi. The microvilli or the brush border were either absent or blunted on the surfaces, which could demonstrate impaired function of this placenta. And as shown in the light microscopy, we also showed syncytiotrophs disruption and then the red blood cell adhesion. And I'll show you a few of the images. So this placenta of HIV negative at preterm placenta. And this is from HIV positive term scanning electron microscopy. And you can see the break of the syncytium, the features of the shriveling, and we have the blunting of the buds, the terminal buds in the placental tissue. And you can see an obvious difference between the two. These features of delamination and with the seems to be recruiting inflammatory cells, the macrophages here. These are the platelets, and so there could be an adhesion and inflammation at this particular point. And this shows the blunting or the balding of the syncytium in the two groups, the HIV positive and this HIV negative. These are the microvilli which facilitate the improper function of this placenta. And this shows the blunting of this same with the laying in of significantly large amount of fibrin material. So we went on to demonstrate, to find out whether these features were just on the cell surface or could be seen within the cellular, the cell itself, and to look at their morphological composition changes within the cell that could implicate that we do not have good integrity of this pregnancy. And so we did this using the transmission electron microscopy. So we used the standard method of preparation for electron microscopy, then went on to stain and then visualize with Zen Malin. We did the same work in South Africa. And here we found, if you look at HIV negative, HIV positive, generally you see the features of karyokinesis in the nucleus. They seem to be shrinking and losing their nuclear membrane kind of integrity. And then there's vascular degeneration within these particular cells. So the same features you'll be able to see from HIV positive, quite a bit of vascular degeneration of these cells. And so comments here, we demonstrated that significantly HIV positive and on patients on antiretrovirals showed changes in the placenta that could explain the adverse pregnancy outcomes. And as a matter of fact, the shrinking and changes in the cell surface of this placenta have been demonstrated in other infections and also been demonstrated in features with adverse pregnancy outcomes such as intrauterine growth restriction and preeclampsia. And we demonstrated some of these reduced dimensions in our paper on the preterm birth using just the normal histology. The withering of this syncytium may be due to lack of ability to degenerate of the trophoblast, and then the loss of microvilli also has been demonstrated in this other pregnancy outcomes as I've demonstrated here before. So importantly also that we have this extensive fibrillar meshwork laying that we also showed in light microscopy and red cell adhesion. And this could be explained as a result of attempt to repair and a tender inflammatory process that takes place, resulting in extensive laying of the fibrillar network. So in summary, that there are structural differences in the placenta of HIV positive women on antiretrovirals could be related to immune activation, and therefore this need to understand the downstream biological mechanisms that could be taking place. So we're suggesting that in future works, which we are already doing, is to look at deep in-depth of the cell using the transmission electron microscopy to look at what are other cellular organelle changes that occur in these particular cells. Using placental explants, try to decipher which regimens of antiretrovirals are the ones being the major culprits of these particular changes, and then do transcriptomes and proteomics for this work to be able to see the actual changes in terms of the gene expression and which kind of metabolite products that are produced by these particular cells. So thank you very much for your engagement.
Thank you. Thank you indeed, Professor Obimbo, for such fascinating work. Please stand by because there'll be questions on this and we will have a Q&A session. So please also use the Q&A to put down your questions to any speaker so that at the right time we shall get answers to those questions. There's also an announcement about CPD. You need to email KNH for CPD for that. Now, we move on. Our next speaker is Professor Antony Wagnero. He's an associate professor in the Department of Obstetrics, Gynecology at Kenyatta University. And he will be giving us a talk on strengthening data in maternal neonatal health with lessons from one of the counties where he has worked. So welcome, Professor Wagnero, to take us through the session.
Thank you, Professor Amaro, and thank you, the organizers. If I can have my slides up, Dr. Kinodia. Kenyatta team, can I have my slides up?
Yeah, we are having a small team with the slide. Had you downloaded them or we continue trying to sort it out on our side?
Maybe I can share them.
Yeah, we are having a small problem
on my
here.
side?
Yes, because of the size.
Let me try to get them if you have it. Health. And this is the experience that we had from the preterm birth initiative, which was a study that we did in Migori County. So this will be the outline of my presentation. I'll give you a brief background on the implementation science studies, the PTBI implementation package, how we did data strengthening, and the results and lessons learned, and also the takeaway, the take-home messages. So basically, the study we did was an excellent example of an implementation research trial. And this type of studies are done in real life settings. And so they are complex and usually you need to be very adaptive to the situation, as you can see what we found on the ground. This type of studies, basically, the implementers are usually the health workers who are already working in the facilities. So the PTBI was a pair-matched cluster randomized controlled trial. We conducted it in Uganda and also in Kenya among government-run facilities. So we had 20 facilities, 16 in Migori and 4 in Uganda in the Busoga region. What was unique was that the facilities, both in Uganda and in Kenya, had the same indicators: the neonatal mortality rates, the stillbirth rates, the PTB, the preterm birth rates were almost similar, and that's why we went to the 2 regions. So the PTBI interventions were basically 4. And 2 of these, which are the data strengthening, which we are going to talk about today, and the modified safe childbirth checklist were implemented in all the facilities. Where in the experimental facilities, we implemented all the 4. So they also included the quality improvement, collaborative cycles, as well as pronto simulation and training for teams. The main objective for this study was to reduce preterm mortality, and our aim was that with implementation of the 4 interventions, we'll reduce the preterm birth rate by up to 30%. So you may ask why we decided to do data strengthening. But when we began this study, we agreed amongst ourselves, among the stakeholders, and also among the funders, that it was very important and variable for countries' healthcare system if researchers can use existing data sources. And also at the same time, try to strengthen the data sources within the facilities, thus reducing the risk of creating parallel data systems. So our study relied basically on the routine health services data, which was being collected within the health system. And we thought that strengthening this would increase or will have the potential for a path towards improvement of data quality and create capacity as well as sustainability in as far as maternal, neonatal, and child health data is concerned. So these are some of the elements of quality data. And they include the fact that the quality data should be valid. So it should be able to measure what they are supposed to measure. It should also be reliable, such that every person is able to define and measure the same way all the time. It should also be complete, that we don't miss some variables, and then we should also be precise. It should be timely so that we are able to retrieve the data when we need it as we take care of our patient. And of course, it should also be having some integrity. So when we talk about quality data, we say that we look at it as how well our data tell the truth as it is. So is it representative of what is happening on the ground? And surprisingly, what we know is that most of the data that we have from on the ground is actually not quality. And that's why we went in and decided to strengthen the data. So our method, basically, what we did initially was to review indicators with the healthcare providers so that all of us understood the indicator definition and also the standard indicators for perinatal and preterm births. We also provided tools to the healthcare providers so that they could be able to improve the gestational age assessment, which when you are looking at perinatal issues, including term and preterm births, you'll find that if you don't get gestational age assessment correctly, then you are likely to miss some of these data. Our team from the data team, they did monthly site visits where they would collect the registered data and try to collect it for completeness and correctiveness with the other data sources. And then they would give feedback to the healthcare providers so that we could have improvement. Then, of course, we created an online data dashboard, which was site-specific, and we gave the sites the authority to use the data on the dashboard so that they can be able to improve the various indicators. We also did biannual data quality assessments and disseminated the results to the stakeholders. So for data strengthening, our target were through groups. So we had the maternal, the maternity ward and the pediatric ward providers who basically are the generators of data. We also had the data custodians who are the health record officers and the staff. And of course, we also targeted the administrator the various administrators in the facilities for feedback, because these are basically the ones who will implement and also provide the resources for quality improvement within the MNH structure. So I'll give the results on how we managed, and on this slide, what you are seeing is the dashboard. And you can see that this dashboard, the one we created, had the elements of a good dashboard, where you could get graphical representation of data for easy understanding. The facility providers could also be able to quickly do assessment of how the facility was performing, and how the problems that could be seen just at a glance, and try to rectify any problem that they could see. On this slide, the main thing is to look at the challenges that we found when we went in on the issues of gestational age. This was data that we collected at the beginning as baseline data in 2016. And what I want you to see on the slide is the range of the gestational age, the calculated gestational age that we found. We found that this ranged, when we checked the last menstrual period, the recorded last menstrual period on the patient charts, and then we calculated the gestational age as per the recorded last menstrual period, then we found that the gestational age by weeks ranged from -14 all the way to 92 weeks, which is more than 2 times the gestational age that we know, the normal gestational age of a human being. The other thing that was also surprising was the difference between the recorded and the calculated, and it could only match in about 30% of the entries that we found. So you can see there are many errors when you are talking about perinatal health, and because of course the gestational age is very important when we are taking care of these perinates, because it's the only time that we can know this perinate is either underweight or large for gestational age, or it is a preterm or a normal term baby. What about record keeping? Record keeping is another area that when you are doing studies, we need to really think about, and we need to strengthen record keeping and record storage in the facilities. So we know that our facilities depend on paper-based record keeping, and there are challenges in storage, and this makes also the issue of security of these records to be critical. So of course, what we found was that, of course, like all the facilities, the records were haphazardly kept, and it was very hard to retrieve any records. But as we went on during the study period, we renovated the spaces that were there, and you can see on the right side a well-renovated record space in one of the facilities, and this made it easier to retrieve the issue of data and to improve the timeliness of accessing this data as per the definition of quality data. So these are some of the results, and you can see that chart traceability improved drastically from the baseline, which was 2016, where we could only be able to retrieve about 70%, and this improved gradually over the next data quality assessment. It went to 88%, and by March 2019, we had already moved to 90%. Of course, this, when we looked at the statistical difference, we found that this was statistically significant. The next thing that we looked at was the data matching across data sources. We know that maternal neonatal child health data and more so the perinate data, the data that we generate during delivery and immediate after delivery, is kept in two forms. So when a mother is admitted or on being admitted, the mother gets, her data is put into the maternity register. Then the mother gets a file, then the patient is cracked and is managed. But at the end of the day, we would expect that the data from the patient chart, when the mother delivers, of course, there are some things like the gestational age, the weight, the discharge status, and the date of delivery that should also be filled in again in the maternity register. However, when we went in, we found that the two data sets were not speaking to each other. And you can say that the matching of the data was only, like if you look at the gestational age, was only 34% at the beginning. The birth weight was 81. Then, of course, the baby's discharge from the patient chart and the maternity register, they could only match in up to 65%. As we went on with the project, we found that matching of the key data improved as time went on, and this was also found to be significant. Then what is interesting is that the perinatal data is put from, is mined from the maternity register and aggregated, then it is put in another form called the MOH 711. And this MOH 711 is the form that summarizes the perinatal data to be transmitted to the Ministry of Health, both at the county level and also at the national level. So this is the data that is critical if we are to put resources to the management of the perinatal and as well as, perinate, and including, of course, preterm babies. However, what we found was that there was major variation between the two data sets. We found that what was being reported to the Ministry of Health through the MOH 711 was actually data that was not speaking to the maternity register data. And you can see that, like, if you look at fresh stillbirths, at the beginning, when we went in 2016, the variation was up to 43%. So fewer fresh stillbirths were being reported to the Ministry of Health. The same thing happened with the other variables, including live births. So you can see that there was still a variation of live births. Of course, as we did data strengthening and did mentoring of the facility workers, then this variation reduced with time. And by the end of the study, we could see that things like macerated stillbirth, there was no variation. Of course, there are some areas like the ones that had major variation, like fresh stillbirths, we still had about 80% variation. Then, of course, the completion of the maternity register is critical, and we would expect that this register is completed for all the patients. But of course, what we found at the beginning is that many of the patients' data was missing in the maternity register. But as we progressed working within the facilities, the completion rate increased and it remained at around 93%. So you can see there's still work to be done. We need to do a lot in strengthening data for the perinatal births, for the perinate as well as the preterm births. So this is a paper, one of the papers that we did. It was on an initial paper after the second DQA in 2018, and it was on assessing effects of data quality strengthening campaign on completeness of key fields in both Kenya and Uganda. And what I want us to look at is the conclusion. We concluded in this paper that the data strengthening campaign can have mixed effect on the completion of key maternity register fields, and this could be country specific. So as you start, don't give up, because we found that Uganda did much better and they picked the data strengthening much faster than what we had in Kenya initially. But in the second paper, which is on the outcome of data quality assessment of maternity records across the 17 health facilities in Migori, we found that there was tremendous improvement towards the end. And our conclusion was that targeted regular DQAs or data quality assessment with facility level mentorship and upgrades in record storage can improve the data capture, patient records retrieval, and the quality of data in our maternity unit. The second thing that you can see in both papers is that the authors of this paper included the data assistants, the people who are collecting data in the field. These are groups that we normally also don't mentor as we are doing implementation studies. And you find that we write papers with the people who fund, like the people from the UCSF, and forget the people who generated this data. But in this study, we managed, in every paper, we managed to mentor also the people who are collecting data to be able to be part of the others. And we gave them tasks to work on the papers, and they delivered. So what are my take-home messages? One, we need to continue doing more implementation science studies, despite the fact that they are complex and adaptive, because these are the studies that offer chances of strengthening existing health systems in situ as we conduct the studies. Two, the existing data quality is wanting in our facilities. And what we are getting from the field to the Ministry of Health may be data that is not complete. It doesn't tell the true story. So as we conduct our studies, let us try to strengthen the data systems within the facilities so that we can be able to improve the quality of data that the ministry can be able to work on and budget for our perinates. The third thing is that routine data quality assessment combined with the targeted data strengthening activities, that is in situ feedback and mentorship, can lead to good quality improvement of MNS, maternal neonatal child and perinate and data that can encourage also data use for healthcare improvement, especially for that preterm baby or that term baby who may be in need of something in the facility. So finally, given emerging international priorities around maternal, neonatal, and child health, including the perinate, utilizing facility-based routine data sources, including the registers and the patient files, will be key to ensuring sustainable monitoring and evaluation of our interventions and outcomes. And this will also help in resource allocation for perinatal health. I want to acknowledge, of course, Bill and Merida Gates, who are the funders, the Ptbi East African Group, which was led by UCSF and KEMRI, as well as Makerere University, the Migori County Health, and of course, the mothers who participated in our study. Thank you.
Thank you very, very much, Prof. Wagnero. Excellent talk, and we continue to learn so much from the PTBI study. Please, again, stay on. There are some questions already for you, and I'm sure there'll be many more questions. Before we go to the Q&A session, I'd like to welcome Dr. Gisharu from the University of Nairobi, Pediatrics. to give as a talk on Bad Asphyxia, Dr. Gisharu. The slides are on.
Thank you, Professor Pamalwa. Okay, thank you. Good afternoon. My name is Dr. Gisharu. I will be taking you through this session. The topic is preventing bad asphyxia. And I started with this pictorial diagram showing a neonate or a newborn on a therapeutic hypothermia. And this is specifically a selective head cooling. And we know one of the major complications of bad asphyxia is hypoxic ischemic encephalopathy, which usually leads to a lot of cognitive impairment and disabilities later in life. And this puts a lot of financial burden on these families who take care of these children. And so that is why it's really important for us to put efforts in preventing bad asphyxia. This will be the outline. I'm going to briefly talk about prenatal assessment and management of strategies to prevent bad asphyxia, with also intrapartum assessment. And I'm going to talk about a study that was conducted here in Kenyatta National Hospital on the prevalence and outcomes of perinatal asphyxia before and after an intervention. Next slide, please. Okay, we are going to start with the prenatal assessment. So it's really important to educate these mothers that they need a regular antenatal checkups. And in these antenatal checkups, we are both looking at the mother and the baby. And we also need a high-risk approach. By high-risk approach, I mean that we need to identify mothers who have high-risk deliveries. These are including mothers who have hypertensive diseases in pregnancy, or they have maternal diabetes. And so with getting these high-risk mothers, we are able to anticipate complications during labor and hence carry out timely interventions. And in hospitals that may need or maybe cannot be able maybe to carry out interventions such as cesarean section, it is very important to carry out timely referrals, and also if there is need be that the mother requires a specialist review, let's say a cardiologist review, there's also an importance of placing timely referrals. And in these mothers, for example, who have maybe hypertensive diseases in pregnancy, it is important to manage these mothers as well. Next slide, please. Okay, when we look at the intrapartum period, we are looking at monitoring the fetal heart rate, and I will go directly to monitoring using maybe the cardiotocogram, the electronic fetal monitoring. So we are going to look at, is there any persistent late decelerations of any magnitude, persistent severe variable deceleration, prolonged bradycardia, decreased or absent beat-to-beat variability that can actually indicate or tell you that the baby has asphyxia. Or we are also going to monitor the amniotic fluid color. And in this, we are asking ourselves, is there any big meconium stained amniotic fluid color, which will make us anticipate that we might get meconium aspiration syndrome. And last but not least, immediately after delivery, we see that these babies, most of the babies will fail to initiate and sustain breathing at the time of birth. And so we need to carry out effective resuscitation. And for the resuscitation to be successful, one, we need to anticipate, and anticipation is by getting maybe to the labor ward, if it's a pediatrician or a neonatologist or the healthcare worker receiving the baby, need to get a bit of history about the mother. Maybe it's a mom who had maybe an infection in pregnancy, and this is a preterm delivery. So you need to anticipate the complications or the disease processes that might occur in this newborn, adequate preparation, and timely evaluation with quick and correct action. I named just but a few of the equipment that we need for preparation, which include the warm towels, suction devices, bag, valve, and mask, as depicted on that picture. And this is just an illustration of what we need as the pediatric team, what we frequently need or what we need less, and what we rarely do. So for the first part is immediately after delivery, assessment of the baby is really, really important. And when you're doing this assessment, you're making sure that the baby is warm and stimulating the baby to breathe by drying. And at the same time, you're doing your ABGA scoring. And by ABGA scoring, I mean you're looking at the appearance. Is this baby pale or blue or pink? We are checking the pulse. We are checking the grimace activity and also respiration. What we frequently don't do or rarely do is mostly endotracheal intubation. This is done especially when the basic resuscitative measures have not improved. And so the endotracheal intubation and administration of the drugs are the last things that we do to these newborns. Next, please. And so we come to the study done at KNH. It was a retrospective descriptive study conducted by myself, Dr. Laving, a pediatric gastroenterologist and senior consultant and lecturer at the University of Nairobi, Professor Duati, a professor and also an infectious disease specialist and consultant at the University of Nairobi, and Dr. Murila, who is a neonatologist and also a senior lecturer at the University of Nairobi. And the study was on the prevalence and outcomes of neonates admitted with perinatal asphyxia, pre and post introduction of enhanced newborn care at Kenyatta National Hospital. The broad objective was to determine the impact of a quality intervention of enhanced care achieved by posting pediatric residents to maternity unit at Kenyatta National Hospital on the prevalence and outcome of perinatal asphyxia. So this basically forms the basis of the study. So we had 2 time periods, and period 1 was between January to July of 2018, where the pediatric residents would review babies only when consulted, against a period 2, which was in January to July of 2019, where we had residents actually rotating, being assigned to labor ward. It was a 24-hour shift where the resident was the team leader. And these residents used to review all high-risk women, attend all cesarean deliveries, and also were able to review babies post-delivery. Going into the results, this is a table which shows the prevalence of ABGA scores of less than 7 for babies born in Kenyatta National Hospital maternity labor ward in January 2018 and 2019 respectively. We can note that babies who scored an ABGA score of less than 7 at 1 minute were actually more in 2019 at 50.8% compared to 2018 at 13%, which we postulate that this could have been due to a period where there was an industrial action by healthcare workers, a strike as I can call it. So we tended to get more sicker women coming into the facility. And if we compare those babies who had an ABGA score of less than 7 at 5 minutes, we had lesser or fewer neonates in 2019 when the residents were in labor ward at 7.8% as compared to 10.1%. And this, we also compared those who had an ABGA score of less than 7 at 1 minute and improved to more than 7 at 5 minutes. And we actually see that, sorry, the table has been cut. We had a lot of babies improving in 2019 when the residents were in labor ward at 84.6% as compared to 19.9%. And we can see that babies who were born in 2019 had 22.2 higher odds of improving from an APGAR of less than 7 at 1 minute to an APGAR of more than 7 at 5 minutes when the residents were there. And it was statistically significant at a p-value of 0.001. On comparing the outcome of these babies, one at labor ward and at the newborn unit, we found out that there was a significant reduction in newborn deaths in labor ward. We can see that we had 4% of these newborns dying in 2018 as compared to 1.2% of newborns dying in 2019 when the residents were rotating in labor ward. And this was a 70% decline in the newborn deaths in labor ward. And the relative risk at 0.3 shows that there was a 70% lower risk of babies dying when they were born at during the intervention period in 2019 when the residents were in labor ward as compared to 2018. We also saw that we had a reduction in the overall admissions in the newborn unit from 10.1% to 7.8%, with a reduction in also death attributed to asphyxia in newborn unit at from 5.8% in 2018 to 2.9% in 2019. That was a 50% reduction. And we saw that the babies who were born in 2019 when residents were in labor ward had a 30% lower risk of dying as compared to babies who were born in 2018. When we look at the overall mortality, and this is mortality both in labor ward and in the newborn unit, we had a 58% decline where we had a 9.8% in 2018 as compared to 4.1% in 2019. And we got to see that when the babies were born, when the residents were in labor ward rotation, they had a 60% lower risk of dying as compared to babies who were born in the non-intervention year in 2018. And all these values were statistically significant with probability values going also less than 0.001. These are the results. So we also found, we looked at the prevalence of bad asphyxia in the newborn unit. And in 2018, we had a prevalence of 28.3%. With 2019, when the residents were in labor ward, we had a prevalence of 22.4% of bad asphyxia in newborn unit. And we can see that we had a drop in the prevalence of bad asphyxia by 5.9% after the resident doctors started rotating at labor ward. On comparing the outcomes of these neonates who were admitted to the newborn unit, we can appreciate that we had at day 7 of life, we had more babies surviving in 2019 when the residents were in labor ward at 73.61% as compared to 56.04%. And we had a reduced number of those who died in 2019 as compared to 2018 at 26.4% and approximately 44% in 2018. And so we saw that babies who were born in 2019 had 40% less risk of dying by day 7 of life when there was a rotation of the pediatric residents as compared to when there was no rotation in labor ward. So we also looked at the risk factors that were associated with bad asphyxia, both neonatal and maternal factors. And what we found out was that gestational size, especially the small for gestational age babies, had higher odds, approximately 4.1 higher odds of having bad asphyxia as compared to babies who are appropriate for gestation. And this was statistically significant, probability value of 0.001. Women, maternal age was also a significant risk factors with women who are above or equal to 35 years of age being having an increased risk of getting babies with bad asphyxia, with a prolonged second stage of labor, also having higher odds at 17%, and also women who had hypertensive disease in pregnancy had approximately 43% higher odds of having babies with bad asphyxia, and these results were also statistically significant. In conclusion, the key findings from our study was that in labor ward, we found that newborns who were delivered in 2019, when there was an intervention in labor ward, were more likely to improve after resuscitation. We had 70% decline in newborn deaths. In the newborn unit, we also had a 50% decline in asphyxia-related deaths, and also a 58% decline in overall mortality. And we were right to conclude that having pediatric residents rotating in labor ward actually improved asphyxia-related outcomes. Okay, as part of our recommendation, we recommend that we have a full-time team present in labor ward or the maternity theater, in short, the maternity unit during deliveries for the care of the newborn babies. And we encourage collaboration between the obstetrics and pediatrics team. And as a take-home message, we appreciate that when we have a skilled personnel as the first contact of a newborn at the time of birth, it actually improves outcomes of this neonate. And this skilled personnel can be a pediatrician, can be a neonatologist attending a delivery. And if there is none of this cadre present, we need to equip ourselves with skills of effective resuscitation so that we can avert bad asphyxia. And also to reiterate, we need to pick up these patients with comorbidities so that we can be able to anticipate any complications and also communicate to the pediatricians so that we can be able to ensure that there is a healthy mother and also a healthy baby.
Thank you. Thank you very much.
Thank you. Thank you.
Thank you. Thank you, Dr. Gisharo. Colleagues will take a break now to, not a break really, a pause to take your questions. I'll start this off and then I'll hand over to Dr. Kihara. First questions going to Professor Wagnero. I think I'll just read a series of questions for you, then you can respond to them as you'd like. So the first one is a comment. Indeed, reproductive maternal newborn and child health data reporting system lags behind in many aspects due to less focus on the quality, many data collection tools, poor understanding of the indicators. And the question is, in your study, did you include private facilities? And how, if so, how do they compare to the public facilities? That's the first question. I'm going to ask a few others. The second one is, have you developed a tool that could lead to mandatory data entry? This from Dr. Wambani Sidika, and another one again. Oh yeah, so that's for Dr. Prof. Wagnero. I have two other questions here. I'd like to know how much it costs the study to implement these data improvement steps, if you have costed them. I'm coming from a point of ensuring that they are sustained beyond the study. How much did it cost? And then in addition, there were many things and they're all important, but if a manager was to learn from you, where do they start? Maybe if you could just break it down in simple terms, you'd say this is perhaps where you should look first, and then the next one. And finally, now that we have COVID and a lot of things have gone electronic, what difference do you think this makes in data collections? Prof. Wagnero, I think you could take those questions in any order that you wish.
Yeah, thank you, Professor Pamalwa. I think those are great questions. So I'll attempt to answer them. The first question was on, of course, the constraint of reporting maternal neonatal child health data. And we know, of course, it lags behind. And the reason why we think it lags behind is that we have not created an environment or a tradition where us as healthcare providers recognize the role of this data. So it is when we create this environment that we will be able to get quality data. And when we realize how important accurate and quality data is to the care of our mothers and also the babies. So yes, did we involve some private facilities? Yes, we did. We had some, we said we had some government hospitals and also missionary hospitals. But what we realize is that the missionary hospitals, other than for the issue of space, that they had better spaces for storing the charts, they did not do any better than the government hospitals in as far as the quality of data was concerned. And this is a problem because of issues of indicator definitions and also standardization of the definitions as well as the processes. A good example is the issue of gestational age assessment. You'll find that many of the facility providers will do not or use different types of gestational age assessments. And of course, you cannot blame them completely because we also lack early ultrasound in many of these facilities. So you'll find that, of course, some people will use the last menstrual period, which many of our patients cannot remember. Then they will go to the assessing the fundal height, and you find that most of the times we don't use the tape measure to do the SYMPOSIUM fundal height assessment. And of course, some people will assess and look at the weight of the baby after the baby is delivered to get to the gestational age. So that's why you find there is a big variance in the gestational age. So the issue of data tools, have we developed one? I can say yes and no. One, remember we are doing this as a form of implementation study. And what we realize is that data collection tools and the data aggregation tools are there. We have the maternity register, which is a very well summarized tool. We also have the MOH 711, which is the reporting tool from the maternity register to the MOH. And of course, we have the patient files. But it still boils down to the incompleteness of the data that is inserted, and the fact that these tools cannot speak to each other. But what I believe we did is that, of course, the issue of an online dashboard that can be used within the facilities would be very critical. And putting these quality improvement cycles, because the dashboard is able to graphically tell you which indicators are not doing very well. If it is completion of the birth weight, it can tell you now we are only able to complete 95%. So you can go back as a form of quality improvement cycle and look at where are the bottlenecks. And working with the staff, we can be able to improve on that. Of course, we cannot make data collection or mandatory. We have to work in tandem and in collaboration with the people who are generating the data, and that is the midwives, and make them recognize how important this data is in being recognized, what they are doing in improving the outcome of their patient, and also in getting resources. So, and that is the only way probably we will be able to win the issue, the battle of data quality. The other question was, what can I tell to the manager or the management team? The main thing is basically is for them also to recognize that the issue of quality of data falls is central to the care of the patients. And it does not need a lot of resources. What is needed is actually to create that culture, that feeling that, yes, without quality data, our perinatal outcomes will always be bad. Without quality data, our maternal outcomes will always be bad, because we will deliver maybe 100 mothers, get 5 stillbirths for this and this reason, but we will not be able to put resources to be able to improve, to be able to address those stillbirths if we don't generate the right data. Then the issue of COVID-19 and the generation of or use of electrical data capture system. This is, of course, a key thing. And we know that, of course, it costs quite a bit of money to be able to put an electronic health system. And knowing where we are coming from, that in most of our facility, or in all our facility, other than the big one like NPRH and KNH, and a place like Vika, which was used as to try some system, most of the other facilities do not have electronic health data systems. But if this can be got, because you can put flyers in this such a system, so that if some data is not captured, then this is flagged off electronically. This would be good, but I think we are still quite far. We need quite a bit of resources to be able to achieve that level where we can say all our health facilities can be able to have electronic health data systems. What was the cost of implementation of this study? Remember, this was only one of the 4 interventions that we did. And we can say that the 2, the safe childbirth checklist and the data strengthening did not cost much, because we were using, all we were doing is that, other than employing 8 data personnel to be able to be going to the facility every month, collect the data, and give feedback and mentor the hospital staff on the issue of data quality, we did not need to put any resources, other than, of course, the resource in improving the data storage facilities. Thank you.
Thank you very much. There's another question for you from Elizabeth Irungu. I guess it is for you. KNH being a hub of innovation, what's your vision of implementation science as a separate discipline in normal practice? And this is asked because of the grueling nature of clinical practice, where in some setting, implementation science is seen as a separate discipline. What would be the role or vision for KNH, and this should not just be KNH really. I think KNH should be other institutions, other tertiary institutions. I think that would be the last question for Prof. Then we'll have some questions for Dr. Gisharo.
Thank you.
There's also
thank you.
one more, please. There's part of programmatic reasons for poor data quality, especially in private settings, is the qualification and experience of staff and high staff turnover. Was a study able to assess some of this? It's from Dr. Baraza. Thank you.
Thank you, Dr. Wagnero. I think those are critical questions. I'll start with the second one. High staff turnover is a major problem in anything related to maternal neonatal child perinatal health, because you would train and mentor staff in the maternity unit, and then you'll find that within no time they have been shuffled and taken to another ward. And I think this is a constraint because our resources for health personnel are still poor. But I think the best way to look at it, to approach the issue of data quality, is to look at it as a system-wide thing, where we should mentor everybody within the system. Because whether you're in outpatient, whether you are in maternity, whether you are in orthopedic ward, you need to generate quality data. You need to capture this data. The data needs to be stored in a way that they can be retrieved when it is needed, etc. So if we use a system-wide approach, then we will be able to reduce this issue of high staff reshuffles and turnover. Of course, qualification, I think all staff are basically qualified to collect data. What we know is that they have not been mentored to know the importance of data. So, because of course, remember these staff, other than the HRIOs, the Health Records Information Officers, anybody working within the health system, we just capture the data, and in most of the times, we don't know what happens to this data because our qualification, of course, is not in data. So what we need to do is that we need the people who are knowledgeable in the issues of data to mentor our staff as they generate this data so that they can know what is the importance of this data and how this data is used from the time it is generated at the source all the way to budget allocation at the government level. So the other question was about the vision for implementation science. Yes, I see a time when we will have healthcare providers being trained on implementation science, because as we very well know, the world is now more turning towards implementation science because this is the science that can be quickly be uptaken. It can generate results very fast, and it can be able to be used to change quality very fast because you can see the improvement as you go along. So it should be in the pipeline of the universities and the higher learning institutions to have courses in implementation sciences. Thank you.
Thank you very much, Professor Wagnero. I'm really appreciative that you gave us this talk on data. There are a few things I'd want to add, and particularly in the current context where we're looking at not just quality of care from the provider's perspective. Even amongst us as providers, we're saying, please create an enabling environment in which our work can be better. Unless you have data to even inform the administrators some of the constraints you are experiencing, that health system will never change. So data will give you evidence which you can use for research and innovation. It will also give you evidence for actionable elements, and action doesn't always require money. I think that notion people need to get out of their system. It could be just rearranging. You saw the difference in the filing system. Then the issue of policies at ground zero. In other words, you're contextualizing care for the people you're serving at baseline. So what could be causing perinatal mortality in Migori may be very different from what is the problem in Mombasa or in Nairobi. But with data, it will actually contextualize for where you are practicing from. The last thing I think I will also want to emphasize very emphatically is the issue of social accountability. Social accountability. Communities are now beginning to demand that certain things must be in place in a health system or in a health facility to optimize the patient's experience and satisfaction with care. Unless we're interrogating data to inform our practices, to inform policies, and eventually inform the advocacy messages, we will just continue going round in circles and complaining. It's a high time. We are in the 21st century. Real-time data, most of us, in fact, all of us have a mobile phone, and we have softwares which we can utilize. So I think the issue that it's going to take a very long time, the same way we were kickstarted by COVID, into having embracing of technology, we have to embrace it for data. I have only one concern. The records person or the health information system has always been renegated at a little corner in a hospital. I think we need to bring them into the forefront, not in that little corner. Point of care recording requires real time and their presence on a day-to-day basis. I'll stop there because I'm one implementation science person, and I believe that's the way to go, and that's what we need to embrace very strongly. So I'll ask our next presenter, Geshero, you did a very good job. We do have a set of questions for you, which I will just read through. What prevented there being a pediatric team in attendance in the earlier period of your study? And what was put in place to have them in the latter period of your study? Were the pediatric team retained for every delivery as recommended in your study? If not, why? That's one question. So maybe you can answer that.
Okay, thank you for the question. Very valid. I'll start by what prevented there being a pediatrics team in attendance in the earlier period of the study. So the main reason is we've been having issues with the fluctuating numbers of pediatric residents. So like, for example, in 2018, there were very few residents who were admitted at the University of Nairobi. And so the team that was present at the time could only cover the newborn unit and the wards. So the labor ward rotation was actually not in place. But now in 2019, we had a significantly higher number of residents, and that is when actually the rotation was put in place. It was quite new. It's not happened in the curriculum at the University of Nairobi. And of note is that the data is not yet published. It's actually data that we got like 4 weeks ago. So I believe that we are working towards this recommendation, and I believe that it can form a basis of now having a policy or a guideline for having this set of people in the labor ward now. Thank you.
So what would your comment be? Because on a practical footage, I'm looking at even the confidential inquiries on maternal mortality and perinatal mortality. You're finding you do not have the high end, you don't have the pediatrician, you don't have the obstetrician available at every birth. What would you actually feel would be the way forward? If I'm sitting in Isiolo, I'm sitting in Maralal.
Okay, thank you. I believe that we should have more training of the healthcare workers, ideally everybody who is working at at the maternity unit, and not only the maternity unit, every healthcare worker should be trained to have resuscitation skills, to be able to cater for these babies when they are delivered. And not only resuscitation skills, also communication between colleagues, the obstetric team, with the midwives or people who are going to be attending to these babies.
Thank you. I'm even agreeing with what Dr. Gedai is saying. Exploring newborn unit nurses as part of the team that attends a delivery. And I know there is this big push with the Midwifery Association and taking us back to having it as an independent or autonomous discipline, where I believe very strongly, majority of our deliveries in Kenya are by the frontline midwife. So going back to now providing the MONOC training, which is obstetric and neonatal emergencies, I think that would be a win-win for survival. I can see Prof. Ruth Duarte. I would wish you to comment there briefly, because you're the one who even brought on my registrar to talk about this.
Yeah, thank you very much, Dr. Kihara. I too am a very much implementation science person. I think the key in this intervention is having a dedicated baby team in labor ward. Mm-hmm. A team that your business is just the babies. The newborn resuscitation that we carry out, the midwives know how to do it. Mm-hmm. Medical officers know how to do it. Everybody knows how to do it. But the problem is whether the baby is being prioritized. And if you're in a situation like you have a mother who has eclampsia and is having a seizure or whatever, that's where the priority is. So if the labor ward is not organized, that this team are dealing with the babies and this team is dealing with the mothers, then you end up with this situation where the baby's needs are not met. And then we've had a series of studies looking at newborns in KNH, and all the pointers point to the need for a dedicated pediatric team within the labor ward, so that things are identified at source and sorted out before the babies leave that labor ward. Thank you.
Thank you very much, Professor Duarte. I know we have an audience that's coming from far and wide. I would wish to hear a comment from a practical standpoint. You know, in one of the counties where you actually have challenges, particularly with the preterm perinate. You know, just give us a narrative as we wait for our colleagues who are coming online now to come and speak to us in the last two topics. Anybody? You can unmute or ask to be unmuted.
And maybe I can make a comment.
Okay, go ahead, Prof.
In our department, we have had residents doing dissertations based on studies in some of the county hospitals. Mm-hmm. And by far, the commonest reason why you have preterm babies is mothers who have hypertensive disease in pregnancy, whether it's they had hypertension and it just got worse during pregnancy, or whether it is the eclampsia, preeclampsia cluster. That seems to be the commonest reason that they present with a preterm delivery. And some of the challenges have, at least when some of the studies were done, is a lack of diagnosis, timely diagnosis. In many facilities, a mother will get a dipstick urinalysis on the first day that they book into clinic, but there isn't subsequent dipstick urinalysis at every visit. So even if she's going into PET, having proteinuria in urine, it's not diagnosed. Mm-hmm. In other facilities, there was a time, and I hope this has improved, there would be a time where the BP machine, the only BP machine in the outpatient, is shared between the ANC and the outpatient. So it's possible that someone comes in for their visit and they don't get a blood pressure measurement. So those to me seem to are what really stood out in terms of preterm delivery. In terms of perinatal outcomes, there's a cluster of babies, late preterms. You know, those two late preterms, the baby who looks like a normal looks like a enormous weight baby. They even may be more than 2,500 grams, so they're not being clustered as a low birth weight infant, but they are a late preterm. We have, I think, 1 or 2 studies that show that they have increased risk of mortality compared to the baby who's really fully preterm. Thank you.
Thank you very much, Professor Duarte. Dr. Gegai, you have your experience coming in from out there, call it the upper world or high world, whatever they want to call it. What is your experience with addressing perinatal health?
Yeah, I can give some perspective, but COVID has shown us that no healthcare system is perfect in the world. We also have our own problems. And yes. I'm also learning that there are a lot of strengths I'm picking from KNH, the KNH team as well as I listen here. However, I want to give some input on, at every obstetric handover, we usually have a checklist when we have labor ward boards, and we have a checklist on paper that we have to declare. Has somebody spoken to the neonatal team, the NICU, to find out about their capacity? That's number one. Do they have beds? Then the other strengths I've seen is networks of care between obstetrics and neonatal teams. So for example, where I am in Nottingham, you find the neonatal unit is part of a network of care of 5 or 6 hospitals. And if they are struggling with capacity or a particular investigation modality, or a member of staff who has a strength in one area required to go to the next hospital, they cooperate quite well. For the sake of, for example, Nairobi, I would expect Kenyatta is in a form of network of care with the surrounding hospitals and surrounding counties. We also have consultants to consultant handover. So, for example, of course, the registrar will prepare the handover information and update their consultant, whether they are on site or they are at home. And then the consultant is the one who phones the other consultant in the other hospital to say that we are doing an intrauterine transfer of ABCD, and do we anticipate a delivery or not, and all that. We also emphasize on transporting the baby when they are still in the mother. So other than a baby getting delivered in, let's say, Derby Hospital, which is 30 minutes away from us, and then the baby being transported separately. So if possible, if there's a window, transport them when they're still in the mother, and the receiving team will organize. And then there are other things that make a difference. For example, if you are thinking of a delivery, have you administered neonatal corticosteroids? And the other one is, have you given magnesium sulfate, at least the loading dose for fetal neuroprotection? The mode of transfer is the ambulance team that is coming to transfer these people. For example, for the case of Kenya, the challenges would be, you've advised a mother to move to the next facility. Are they going there by taxi, or are they going there by a dedicated ambulance service that is capable of, for example, resuscitating a baby should a delivery happen en route? Those are some of the inputs. I'm going to share more tomorrow when we chat about collaborative working. Thank you.
Thank you so much. Professor Wagnero, you have a comment, but before you comment, can I please request ICT to pull in Dr. Soti? He's waiting in the wings to actually make his presentation.
Thank you, Dr. Kihara and Dr. Murevi. Yes, I think for what we found in Migori when we went in, and this is something that has also been found in Uganda, and also in the US, especially among the Latinos who we were also working with, was that one, of course, the intrapartum care and immediate postpartum care for preterm is wanting. People don't prepare for that delivery. They don't give antenatal corticosteroids. They don't give magnesium sulfate. Then the care of the mother during delivery and immediate after delivery, the care for the preterm is not optimum. So if we can be able to mentor dedicated teams who are able to handle mothers within a hospital and have these teams as champions for preterm births, such that they can do in situ mentorship amongst the other staff, then we can be able to have deliveries of preterm where people are well prepared. Of course, the other thing that has also been used, though it has shown different results, some improvements, some worsening, is the issue of the safe childbirth checklist. This is a checklist that has been developed by WHO. It gives you you can be able to tick on what you have done and what you have not done as the labor progresses towards delivery. So if we can have this within our facilities and train people on how to use it, then that may also help in our preparation as we plan to deliver preterms. Of course, skills also have been shown to decay with the time. And we can also try simulation training within the facilities. And this type, the simulation training should be within the facility amongst the staff. So when they do their improvement cycles and they recognize a problem within the intrapartum period, either for a preterm or a term baby, then they can quickly be able to do simulation and try to improve if we have already had champions who are trained in simulation type of training. Thank you.
Thank you, Professor Wagnero, for those comments. Those are very deep and insightful contribution. Now, I want to introduce Dr. Alfredo Soti. I hope you have managed to come in. Dr. Alfredo Soti. Good. If I see the slides, I know he's around. So Dr. Alfredo Soti is actually working in the Department of Obstetrics and Gynecology. He is a PhD holder in epidemiology. Currently, he is a senior lecturer in the Department of Obs and Gyn, but he's also an affiliate associate professor. And this is in the University of Washington in Seattle, USA. Dr. Soti will be talking to us about fetal surveillance. We have touched briefly on it when we had Gesheru talk about the patterns that you do see on cardiotocography. But let us get more insights from him. As the mother continues to carry this child, what is it we should be cognizant of? And what should we flag as a problem for this perinate? So welcome, Dr. Soti.
Thank you so much, Dr. Kihara, for the kind introduction. And I'm grateful to the organizers for giving me the opportunity to present some of this work. Next slide, please. So when we talk about fetal surveillance, it's very important for us to make a distinction between two aspects of fetal surveillance. There is the antepartum aspect of it, which occurs before the onset of labor, and the intrapartum aspect of it, which occurs during labor and delivery process. It's very important for us to understand the differences, because if we don't, then especially when it comes to interpretation of CTGs, people may use intrapartum assessment to interpret antepartum assessment. So it's important to know. The second thing is that the goals and the risks are different at the two different time points, and that is why we need to look at them distinctively. Lastly, that the tools that you use during the antepartum period may be slightly different from those tools that you use in the intrapartum period. I think you just move the slides when I request to. So in the antepartum fetal assessment, the goal is to identify fetuses at risk of adverse outcomes, which include intrauterine fetal demise or neurological complications associated with chronic intrauterine hypoxia. And once you identify these fetuses, then you provide timely interventions to prevent these adverse outcomes. Next slide, please. So what is the principle behind antepartum fetal assessment? And this also applies partially to intrapartum fetal assessment. So if you have a stressful condition, and this could be a medical condition, it could be a congenital fetal problem, it could be a maternal health issue, which acts as a stressor, then it leads to chronic respiratory and nutritional insufficiency. And as a result, the fetus develops some adaptive responses, which includes decreased growth rate. So they have fetal growth restriction. They conserve their energy during this process. And they also have a response of circulatory distribution, which principally has a brain sparing, okay? So there's increased blood flow to the brain to spare the brain and the other vital organs, while the blood flow through the other organs are restricted. And then fetal growth is increased relative to the placental growth, and the placenta becomes a bit more inefficient, even though there's a desire to increase efficiency. And in some cases, there's relative polycythemia to increase the oxygen flow through the placenta. Now, this progressively may lead to decompensation, which leads to fetal hypoxia, respiratory and metabolic acidosis, with subsequent uteroplacental circulation reduction. And because of the changes in the uteroplacental circulation, and also because of the reduced blood flow to less vital organs like the kidneys, there will be reduced amniotic fluid volume, reduced fetal movement, reduced variability from the CTG, reduced reactivity or loss of reactivity, and in the extreme form, persistent late decelerations resulting in fetal death. Next slide, please. So who are candidates for antepartum fetal assessment? There are many indications. I would just generally say that any pregnancy in which we have identified increased risk of antepartum fetal demise should be offered antepartum fetal assessment. And the list is endless. It could be diabetes, hypertensive disorders in pregnancy, growth restriction, twin pregnancy, postpartum pregnancy, or patients coming in with reduced fetal movement at whatever gestational age. Other medical conditions, as we've talked about as well, would also be indications for antepartum fetal assessment. Next slide, please. So what are the tools or the methods that we have for antepartum fetal assessment? So fetal movement counting is one of the easiest and the commonest tools that we have, although we have caveats to it, especially when you have fetuses at risk of fetal demise. We have cardiotocographic techniques. And in this category, we have non-stress tests, NST, and contraction stress test or CST. Then we have sonographic approaches, which include the biophysical profile, the modified biophysical profile, Doppler studies, which include Doppler Velocimetry of the umbilical artery, middle cerebral, fetal veins, and uterine artery as well. I'll mention some of these a little bit later. Next slide. So fetal movement counting is one of the easiest and available tools, and it's thought that fetal movement decreases in response to fetal hypoxia. And if patients present with reduced fetal movement, it's not an end to itself. They require further fetal assessment. Now, studies and Cochrane reviews as well indicate that there's no clear fetal movement cutoff or threshold which you may consider as an alarm limit. Now, we know we have used several approaches, like having 10 kicks in 12 hours, for instance, but when these have been subjected to rigorous studies, they have not been shown to contribute immensely to reducing some of the adverse fetal outcomes. So in as much as we encourage the mothers to at least report some reduction in fetal movement, we do not have objective tools to say this is the exact number that that you need to reduce adverse outcomes. But it's important for us still to remember that if women present with reduced fetal movement, we do not ignore, and we have to subject those fetuses to further assessment. Next slide, please. Next slide. So what about the cardiotocographic technique? So cardiotocography is just a graphical recording of the fetal heart rate and uterine contractions over time if they are available. There are two, as I've said, non-stress tests, which is just a CTG without contractions, and a contraction stress test, which is a CTG performed with contractions. So it's very, very important for us to make this distinction, because if you just say a CTG was done, it does not really specify whether this was an NST or a CST. Next. So when we perform an NST where there are no uterine contraction, the antepartum period, we need to know the normal, because if you don't know the normal, then you are not able to identify when the abnormalities, and which are the normal characteristics of or features of a normal NST. One, the baseline fetal heart rate should be within the normal range, which is 110 to 160. So if you have values less than 110 or values higher than 160, then those should be a cause for concern that requires further evaluation. There should be a normal baseline variability, which I'll talk about later. And there have to be 2 accelerations within a 20-minute period. And if you're not able to obtain that within a 20-minute period, then you extend it to a 40-minute period. And that is what refers to reactivity. And this is unique to a non-stress test, and you should not use it when you're doing an intrapartum fetal evaluation. So accelerations are defined as 15 beats above the baseline, lasting about 15 seconds or more, especially after 32 weeks of gestation. And the theory behind this is that fetal movement increases sympathetic stimulation from the cardiorespiratory center, leading to increase in fetal heart rate, cardiac output, and uptake of oxygen from the placenta. So this may not occur in situations where there is placental insufficiency. And reactivity is having those 2 or more accelerations within a 20-minute period, and if not possible, within a 40-minute period. And a normal NST should not have any decelerations ideally. Next slide. So this is an example of a normal NST where you have a baseline of about 130. You have several accelerations, as you can see, okay? And there's no deceleration. Next. So baseline variability is very, very important. And it is normal if there is a balanced sympathetic and parasympathetic stimulation from the cardioregulatory center. And a normal baseline variability is highly predictive of a well-oxygenated fetal CNS. The ranges that we normally expect are those between 6 to 25 beats per minute, okay, which is moderate variability. But if you have no amplitude, it will be absent. Minimal is less than 5, and then marked variability is more than 25 beats, and this will often require evaluation because there may be some element of poor oxygenation of the fetal CNS. Next slide, please. So accelerations, again, a caveat that you need to remember is that above 32 weeks or 32 weeks and later, the accelerations are defined by 15 beats above the baseline and 15 seconds, but less than 2 minutes, okay? Less than 32 weeks, because of the maturity of the CRC, the peak would be 10 beats per minute and 10 seconds, but less than 2 minutes as well. So know the values at whatever gestational age you are evaluating the patient at. Otherwise, if you use a 15-beat cutoff at, let's say, 28 or 30 weeks, then you may brand some of these fetuses at not having accelerations, yet it's just because of their relative prematurity. They may be prolonged if they are more than 2 minutes, but less than 10 minutes. However, if they last more than 10 minutes, then that should call a baseline change. Next. Decelerations are basically a symmetrical decrease and return of the fetal heart rate, which is more or less a reversal of the acceleration, and defined by 15 beats per minute, lasting 15 seconds or more, but less than 2 minutes in duration. So basically a reversal of the accelerations, and the onset to nada should be less than 30 seconds. Again, this suggests some element of placental insufficiency and potential hypoxia that we do not typically want in an NST. Next. Now, a contraction stress test, on the other hand, is basically when you have a CTG with contractions in place. And the principle is that if there is adequate placental reserve, if the fetus is actually well oxygenated, then if they have contractions, then there will be no decelerations, okay? Because there is adequate placental reserve. Now, when you have late decelerations following half or more of the contractions, then that would be a positive CST, and a positive CST will be of concern because it would mean that there will be placental insufficiency. So what you really want, and fetal hypoxia, what you really want is a negative where there are no late or significant variable decelerations. However, when you do this, there could be equivocal or unsatisfactory that may require further evaluation. Now, the challenge with a CST, that's why we don't routinely do it, is because you have to simulate uterine contractions, and that may require that the patients are hospitalized typically, and then you have to give IV, IV oxytocin to induce these contractions, and this may make it a bit difficult to do in our setup. Next. Now, in terms of sonography, what do we have? What we have is a biophysical profile. So in as much as you ask for routine ultrasound to evaluate other fetal parameters like fetal weight, gestational age, and the rest, you will also, as part of your antenatal fetal assessment, ask for a biophysical profile. It has 5 indicators, which are either indicators of acute hypoxia or indicators of chronic hypoxia. Okay, so the indicators of acute hypoxia are the NST, the breathing movements, the body movements, and the tone. Okay, and the markers of chronic hypoxia is amniotic fluid volume. Basically, the principle is that a fetus who is chronically hypoxic will have what we talked about as brain sparing. So they have more blood going to the brain and less to the less vital organs like the kidneys. And when this happens, then there's reduced urine production. Therefore, there's reduced amniotic fluid volume. The biophysical profile has been shown to have a direct linear correlation with a fetal pH, such that if you have a poor biophysical profile of, let's say, 0, then there's more acidemia. There's more fetal acidemia. So it's been found in randomized clinical trials to demonstrate that. Now, you can also have, instead of a full profile, you can have a modified biophysical profile where you have just the NST as a marker of acute hypoxia and amniotic fluid volume as a marker of chronic hypoxia. Next slide. So the components of biophysical profile are 4 plus the NST makes them 5, and they are scored as 0 if absent and 2 as present. So there's no 1, there's no odd number. Surprisingly, there are situations where we have found people reporting odd numbers, which is not appropriate, okay? And 2, ideally you should do this over a 30-minute period, but sometimes you may be able to obtain this within a shorter time interval, which may be appropriate. But if you report abnormal biophysical profile and you've not done it over a 30-minute period, then most likely it may be a misleading biophysical profile. Next slide. The next sonographic technique that we have is Doppler Velocimetry. I think I alluded to this earlier, that if you have a fetal growth restriction, or if you have some form of placental insufficiency, then blood is preferentially directed to the brain and other vital organs, and including the heart, and away from others like the kidneys and the liver. So the umbilical artery Doppler indices specifically increase when 60 to 70% of the placental circulation is compromised, okay? The fetal middle cerebral artery, on the other hand, typically falls when there's fetal growth restriction, okay? Because you want to increase placental perfusion, you want to increase brain perfusion and spare the brain as a vital organ. On the other hand, the fetal aortic resistance increases, and eventually, if there's no intervention, then there will be cessation and reversal of end diastolic flow in the umbilical artery, while the resistance increases in the fetal venous system like the ductus venosus and the IVC. These changes have been consistently found to be associated with fetal hypoxia, acidosis, perinatal morbidity, and mortality. So when you get to the level where you have absent or reversal of end diastolic flow in the umbilical artery, then it's time to intervene. Otherwise, you may lose the fetus in utero as you are waiting. Next slide. So the UA Doppler is the most common Doppler technique used for fetal assessment, even in our setting where fetal hypoxemia is a concern, while the fetal middle cerebral peak systolic velocity is the best tool for predicting fetal anemia in at-risk pregnancies, okay? Now, it's important to note that the two of them, especially the middle cerebral artery, is used in conjunction with the umbilical artery Doppler. So you cannot use the MCA alone without umbilical artery, so that at least you are able to see whether there's an increase in the umbilical artery resistance versus a decrease at the level of the middle cerebral artery. Next slide. So this is an example of a normal umbilical artery Doppler, okay? And basically, what you'll have is you have a peak systolic flow, you have an end diastolic flow as well, which you can see very well, okay? So this is a normal umbilical artery Doppler. It's important to know because sometimes the challenge we get now is everybody is reporting to you Doppler studies whenever you request for fetal surveillance, okay? It's only recommended for suspected fetal growth restriction, not if there's a normally growing fetus, okay? So it's important for us to remember that. And it should not be used as a standalone fetal surveillance method, okay? You have to use it in conjunction or in addition to the NST and or the biophysical profile or the modified biophysical profile. So you should not use it alone. Next slide. Now, if you compare this, the previous Doppler that we had versus this, you realize that there's absent end diastolic flow. So there's a gap between the systolic peaks, okay? And then the next one, you have reversed end diastolic flow. So despite the fact that you can't see the diastolic flow, it seems like there's a reversal. So there's blood flowing during diastole, flowing to the maternal side instead of the fetal side. When you see this, then basically it points towards impending fetal demise. Okay, so normally for most of us, once you get the Dopplers done, you also need to look at the images to see whether there's absent or reversed end diastolic flow. Next slide. For those who want further references, you can go to the link perinatology.com. They have calculators which will help you to estimate the indices, the Doppler indices for the different gestational ages, okay? And how you calculate this, because you can also calculate them manually. So this is a resource that you can use for the same. Next slide. What about middle cerebral arteries? So in uncomplicated pregnancies, there's relatively high resistance in the middle cerebral artery. When we have hypoxia, then the blood flow increases to compensate for the decrease in available oxygen. So therefore the impedance goes down. So you have reduced systolic diastolic ratio, you have reduced resistance index, and you have reduced pulsatility index. So basically the principle is you want to have enough blood and enough oxygen going to the brain. As I said, it's a useful adjunct to umbilical artery Doppler studies, and typically is not used alone. So you have to use it in conjunction with umbilical artery Doppler studies to make appropriate inferences. Next. Now, increasingly, we have also been getting report of cerebroplacental ratio, which is basically the middle cerebral artery pulsatility index or resistance index divided by the umbilical artery pulsatility index or resistance index, okay? The principle is that you're just trying to calculate, I mean, you have this brain sparing sort of circulation, so you have increased blood flow to the brain relative to the umbilical artery. So basically, you're trying to calculate that ratio. So a low CPR indicates fetal blood flow redistribution, brain sparing, and threshold values for this have been proposed at different cutoffs of less than 1, 1.05, 1.08, or less than 5th percentile. However, these are not routinely performed. Studies have been mixed. Some have been showing benefit, others have not been showing benefit. So in as much as you get it, you should interpret it with caution, okay? Because we do not have enough evidence to make it a standard recommendation. But we just want to mention it to you so that when you get it, you don't, at least you have an idea what the radiologist was thinking about when he gave you, he or she gave you this ratio. Next slide. The other Doppler studies that you can conduct are on the uterine arteries. It may have some role in third trimester fetal assessment of complicated pregnancies, especially in the setting of hypertensive disorders in pregnancies. So if there's increased impedance or resistive indices or persistent notching at 22 to 24 weeks, this has been associated with increased in preeclampsia, fetal growth restriction, and perinatal death. So again, this is not something that we do routinely in our setting, but when you're handling high-risk pregnancies, is one thing that you can ask the radiologist or the maternal fetal medicine specialist to give you as well. Next slide. Now, so that sums up the antepartum fetal assessment and monitoring, the methods that you have, the options that you have as well. Okay, now I would not go into the details of the management because the management would be rather complex. It will depend on what the patient is presenting with and at what gestational age they are presenting at. For example, if they are presenting at term and you find abnormal findings, then it's time for delivery. If you are presenting early and you have abnormal findings, then you may need to serially monitor them, sometimes weekly or even twice weekly with the options that we have. So briefly, let's look at the intrapartum fetal assessment. Now, the goal of intrapartum fetal assessment is basically to identify the fetus who is at elevated risk for labor-related hypoxic injury so that you can intervene in a timely manner to prevent or reduce the level of that injury, okay? So you do not want a situation where you are monitoring patients who are at risk in labor, okay? You do not identify their risk, and then you end up coming back later to find that you have a stillbirth, or you have a fetus that had a very poor APGAR score, or a fetus that had that has birth asphyxia, for example, or just a fresh stillbirth. Okay. The methods that we have are intermittent auscultation, which you can do with a fetoscope or better with a Doppler, and these are in women who have no antenatal risk factors. Okay. So if patients come in, you'd rather call them low risk or no antenatal risk factors identified, then intermittent auscultation is sufficient, okay? Now, in the past, we have had people offering admission CTG or NST for every patient who presents in labor. No, it's not recommended. It has been associated with increased risk of interventions which are necessary and may not even result in better outcomes, okay? The other option is continuous electronic fetal heart rate monitoring, and this is reserved for those who have antepartum risk factors. Okay, next slide. And even before I move to the next slide, I would say that even though you may have patients who are at low risk or have no risk, somehow during the process of labor, they may become high risk, necessitating continuous electronic fetal heart rate monitoring. So the diagnosis at the time of admission may be low risk or no risk, but later they may change. And if they change, then you have to offer them continuous or electronic fetal heart rate monitoring. Now, when you are offering intrapartum fetal heart rate monitoring, then the interpretation of your CTG will now be different, okay? And this is where you have categories, not classes, categories, category 1, category 2, and category 3. So these categories are not used for an NST for a patient who is not in labor. These are used for patients who are in labor, okay? Because in labor, sometimes the fetal movements may not be there, so you are waiting for accelerations, you may not be able to find them. So lack of accelerations, for example, in labor may not be pathognomonic, okay, as it were when they were in the antepartum period. So you must be familiar with the intrapartum categorization versus the antepartum interpretation of the CTG, okay? So category 1 are those who have a baseline rate which is normal, falling between 110 to 160. So they do not have brady or tachycardia. They have a normal baseline fetal heart rate variability, 6 to 25 beats, which is moderate. They have no late or variable decelerations. They may have early decelerations or not. So early decelerations, as you know, may not be necessarily indicator of fetal hypoxia. And then the accelerations may be present or absent. So the main thing here, apart from the baseline, is the variability. Then we have category 3, okay, where we have absent baseline fetal heart rate variability and either recurrent late decelerations, okay, recurrent variable decelerations, or bradycardia, okay? When you have that category 3, that is an impending fetal demise, and you need to intervene appropriately, okay, and as fast as you can. Then you have category 2, which is neither category 1 or category 3, okay? Next slide. Lastly, especially if you have abnormal, CTG in the intrapartum period like category 3, then where resources permit, okay, and where skills are available, then you can do fetal scalp sampling, okay? I'm just mentioning this for completeness because I know most of us may not be able to do this. We are not familiar with this. They're not experienced with this either, but some of us may have the experience, okay? So the goal is to assess the presence and degree of fetal acidemia from the fetal capillary blood pH and or lactate levels, okay? It is done in conjunction with abnormal CTG. So you'll not go ahead and just do fetal scalp sampling routinely, okay? So you have abnormal CTG. For example, you are thinking it's category 3, okay? And you think that there could be fetal acidemia, then you go ahead and do fetal scalp sampling. For some of us who have more experience with this, like Dr. Gidai, maybe you can give, Francis, you can give more input on this. So lactate more than 4.8 is equivalent to a pH of about 7.2. And when you find that, then you need to deliver immediately. Okay, so you accelerate the delivery. Okay, levels between 4.1 and 4.7 corresponds to a pH of 7.2 to 7.24. And depending on the other factors, okay, you may repeat the sample in 30 minutes to establish the trends, or sooner if the CTG gets worse. Okay, next slide. So in a nutshell, that is how we do antepartum fetal assessment and intrapartum fetal assessment, okay? And my selected references, which I've given in the slides, as well, I relied on society guidelines, different society guidelines to prepare this talk, okay? And also up to date for the latest evidence as well. Thank you.
Thank you very much, Dr. Soti. Dr. Gidai, you'll comment later. I will have,
all right, thank you.
I will have Dr. Guaco come on. I hope he has joined us. Have you? Dr. Guaco, are you in the house?
Dr. Kera, yes, I'm in the house.
Fantastic. Thank you very much. So Dr. Guaco also works in the Department of Obs and Gynae. He's a lecturer. And I must say the latest PhD holder in our department, and has a special interest in addressing stillbirths. I'm using interest quote and unquote. And for this afternoon's session, he will actually give us what he found in a study that he did in 4 tertiary hospitals in Nairobi County, and tell us what the stillbirths issues were in those 4 counties. So welcome, Dr. Guaco.
Thank you so much, Dr. Kihara, for a nice introduction. And thank you, Dr. Soti, for a very good presentation that will actually make mine very easy. I'll start by saying that what Dr. Soti has not told you is the main reason why we do intrapartum fetal monitoring and assessment is so that we have a healthy baby and prevent stillbirths. Actually, with that statement, we can stop there and go home, but let me spend the next 15 minutes to discuss what we found in the Nairobi stillbirth study. My presentation is titled Stillbirths, which is a neglected, invisible, uncounted, and often unregistered tragedy. Now, this is a screenshot that I picked from the World Health Organization that says stillbirths are a neglected tragedy in the sense that they were never captured in the Millennium Development Goals. They were never captured in the Sustainable Development Goals. They're invisible in most programs and policies. Most of the time they are uncounted, and even in our setup, most of the time stillbirths are unregistered. Now, up to 2015, an estimated 2.6 million stillbirths occurred every year. This has slightly reduced to about 2 million as per the latest report that came out last year. And this translates to about 1 stillbirth every 16 seconds. That translates to about 4 stillbirths per minute, which translates to about 200 stillbirths every hour, 5,400 stillbirths per day, and 164,000 stillbirths per month. Now, putting it in raw terms, the biggest aeroplane is, I think, an Airbus A380 that carries about 700 passengers. Now, this 7,000 stillbirths per day actually translates to having about 10 of those Airbuses crashing every single day. You've heard of when there is just one single airline crash, it will be all over the media, but we don't see that happening with stillbirths. Now, 98% of these stillbirths occur in low and middle-income countries, including Africa and including our own country, Kenya. Next slide. Now, the etiology of stillbirths is often multifactorial, with pregnancy and childbirth complications accounting for 10 to 50% of the causes. Maternal infections accounting for about 5 to 12%, and this is based on 3 recent systematic reviews. Medical complications including anemia, HIV, diabetes accounting for about 10 to 50%. Lifestyle factors including obesity, cigarette smoking, alcohol accounting for 7 to 25%, and unexplained in about 25 to 50%, depending on which country you are in. So what are the existing gaps with regard to stillbirths? Sorry, I think the slides are not visible to me. Thank you. So there are about 3 gaps, current gaps with regards to stillbirths. Number 1, as I said, stillbirths were never captured in the Millennium Development Goals. They missed in the Sustainable Development Goals. However, in 2010, the United Nations came up with the Every Newborn Action Plan that sets a target of less than 12 stillbirths per 1,000 births for every country by the year 2030. One of the gaps we are seeing currently is that there's a very slow reduction towards this target as compared to the maternal mortality ratio. Only 94 countries, mainly in North Africa, the Caribbean, Latin America, Canada, and Europe have achieved this. Most of the African countries have actually not achieved this. And at the present speed, somebody said that we'll need about 160 years before a pregnant woman in Africa has the same chance of a baby being born alive as a woman in a high-income country. The third gap is that when we did a literature review, we found that the burden and etiology of stillbirths is largely unknown in Africa. Next slide. Which informed our reason for actually doing the Nairobi stillbirth study, which had 4 objectives. We needed to understand what the latest burden of stillbirth in Nairobi. We needed to understand the main drivers of stillbirths in Nairobi, Kenya, and we also needed to understand what role the quality of antenatal and intrapartum care plays in the causation of stillbirths. Next. The study was largely a hospital-based case control study for objective 2 and 4. For objective 1, we did a cross-sectional study. The setting was in Kenyatta National Hospital, Mama Lucy, Mbagathi, and Pumwani Hospital. These are big hospitals in Nairobi. Our target population were women more than 14 years of age, and the study was done between August 2018 and April 2019. Next. So, what were our findings? Next. During the study period, next slide kindly, there were about 20,000, sorry, before that, there were about 20,000, there's a previous slide, but it's fine. There were about 20,000 deliveries, out of which 720 were stillbirths, which gave us a stillbirth rate of 35 per 1,000, which is actually quite high compared to the target of 12 per 1,000 by the year 2030. We are just 9 years away. Next. So there were about 5 main drivers of stillbirths in Nairobi from our study. So the first driver was that we found an association between antenatal care utilization and stillbirths. Now, women who did not have any antenatal care had a 3-fold higher odds of getting a stillbirth compared to those ones who attended. There was a tendency among women who had more than 4 visits to have a less likelihood of getting a stillbirth. Our study did not find any association between the timing of antenatal care booking and stillbirth. It's not that there was no association. The reasoning here was that generally our ladies book their first antenatal clinic very late. So there was actually no difference, but the reasoning could be because in both the cases and controls, both groups actually do attend their first clinic late. Next. So the second driver that we found was the quality of antenatal care, whereby we found that poor quality antenatal care was actually associated with higher odds of stillbirths. For this one, we used surrogate markers for quality of care. We used basic things like antenatal care, antenatal profile testing, use of obstetric ultrasounds, completeness of antenatal records, administration of tetanus, monitoring of blood pressure and weight, and assessment of conducting a urinalysis in each visit. Now, when we used the individual surrogate markers, the ones that are violated, we actually found that women who had poor quality antenatal care had very high odds of getting a stillbirth. But then at the same time, we computed a composite quality of antenatal care variable that had 7 variables. For somebody to have been said to have had quality antenatal care, they had to have had all the 7 signal functions. On this one, the shocking finding was that our quality of care is actually very low. Only 8.7% of women with live births compared to 5.6% of those ones with stillbirths had received what could be termed as quality antenatal care. Again, I can't see my slides.
IT slides.
IT, kindly. but it's okay, as they are sorting out, we can go on. So the third main driver for stillbirths in Nairobi County was, next slide. Yeah, the third driver was that our study found that hypertensive disorders, antepartum hemorrhage, preterm labor were actually the main obstetric risk factors or drivers for stillbirths, whereby women who had these conditions had a 7.4 to 9.5 higher odds of getting a stillbirth. The only surprising finding on this was among women with preeclampsia without severe features. Now, we found that ladies with preeclampsia without severe features actually had a 9.1 high odds of getting a stillbirth, which was very surprising. We expected this in maybe women with eclampsia or preeclampsia. And our explanation is that probably we don't take seriously women who have preeclampsia without severe features. We deliberately making the decision to deliver, or we don't follow them up closely. Next slide. The fourth driver was medical complications. We looked at about 15 also medical complications, but our main finding was that women with diabetes mellitus, both pre-gestational and gestational, had an almost 12 higher odds of getting a stillbirth compared to women without diabetes mellitus. Recently, I was telling our residents that initially we used to think that NCDs is a disease of the West. NCDs are now with us. The last driver of stillbirths in Nairobi was the quality of intrapartum care, where again we found that women who received poor quality and intrapartum care had 2 to 5 times higher odds of a stillbirth. We measured quality of intrapartum care by assessing the use of a pantograph and by assessing the monitoring of the fetal heart rate as per schedule. In terms of quality of intrapartum care, we also found that women who are referred from other sites had 3 times higher odds of a stillbirth, same as women who delivered through cesarean delivery. Now, over here, I have to clarify that cesarean delivery on its own is actually not a risk factor for stillbirth. However, what it meant is that we delayed in giving this intervention. By the time a good number of our patients went for emergency cesarean section, it was too late, and it resulted in fresh stillbirths. So in summary, next slide, what are we saying? Next slide, kindly. Next slide. Anyway, as the IT is sorting it out, so my next slide was actually on conclusion. So in summary, what we found is that the stillbirth rate is actually very high, 35 per 1,000. We have 9 years to achieve the global target of 12 per 1,000 deliveries. Number 2, we found that hypertensive disorders, diabetes mellitus, antepartum hemorrhage, preterm birth were the main drivers for stillbirths. And number 3, that poor quality intrapartum care referral and delay in conducting cesarean deliveries were the main drivers for fresh stillbirths. Next slide, if you can upload them kindly. IT. Anyway, as the IT is sorting out the slides, so what do these findings mean to the clinical practice and policy? Okay, yeah. So what is the implication of these findings to our practice and policy? What it means is that for Kenya, and we are Kenyans, for us to achieve this target of 12 stillbirths per 1,000 deliveries by the year 2030, number one, we have to improve the utilization and quality of antenatal care. Number two, we have to improve the quality of our intrapartum care, including the use of partograph, fetal heart rate monitoring. Previous slide, kindly. Number three, we have to be very deliberate in how we diagnose, manage, and prevent hypertensive disorders, preterm deliveries, gestational diabetes, and antepartum hemorrhage. I know this will require a lot in terms of political leadership, resource allocation of the human resource, addressing issues of corruption within the hospitals. But from our findings, the drivers of stillbirths are actually things that are very preventable, and the preventive measures are things that we can actually do without even getting the budgetary allocation from the national and county governments. So I think this was my last slide. Sorry about the IT issues, but thank you so much for listening.
Thank you very much, Dr. Gwako, for those insights. So I think what we'll do is just quickly go and address the questions. And since I have one that is really burning in my spirit for Dr. Gwako, how many of these stillbirths were in first-time pregnant women?
That's a very good question, Dr. Kihara. I don't have a specific answer to that, but actually the majority of the stillbirths were first-time stillbirths. They were not recurrent stillbirths. In majority of the patients, it was their first stillbirth. But I don't have the exact number, the exact figure.
Okay, because I think for all of us, we are beginning to see a trend where first-time moms have a lot of issues to grapple with. Financially, addressing the pregnancy, addressing going to the clinic, addressing where to deliver, and even where is the financing coming as a health system? And what kind of a health system do they therefore encounter even when they appear as a 12-year-old or 14-year-old carrying a pregnancy? So I think we all need to reflect. It's just food for thought. But now coming to the questions that we do have, I know there was a comment that somebody had wanted to give. Sadika, maybe we can start with the comment you wanted to make. Maybe because of the presentation's current or what was there before. I'll give you that chance. IT, please unmute Sadika if we're still there. Not there? Is Sadika there? Okay, then I will move quickly. The perinatal outcome in cases of fetal heart. Oh, you're there. Okay. Yes, yeah, go ahead.
I had been muted. Now I've been unmuted. I just want to make some quick comments because yes. I'm glad you organized this symposium. It's very interesting and very educative. Now, I just wanted to make some comments that majority of our population is rural. Mm-hmm. They don't even attend any antenatal care. Mm-hmm. Most of them have home deliveries until they get a problem and then they come to the institutions. we don't have a universal health care program in our country or gynecological care. In as much as we have put things out there in the field, we started Beyond Zero, and then we had an ultrasound machine put in it. We have not been utilizing that particular platform very well to improve on maternal fetal outcomes. So my problem is, in the medical fraternity, we also don't get clear clinical information on the X-ray request or on the imaging request form. And the clinicians are not giving that information. So all those put together, they are definitely going to increase our perinatal and preterm care. In terms of ultrasound, use of ultrasound, ultrasound is very diagnostic in very many areas. And I don't know why we don't have a policy to say that if you are pregnant, you must have a minimum of 2 ultrasound scans. And a minimum of 2 ultrasound scans can really give a lot of clinical information, especially if the clinician adds on their clinical indications for that scan. And if we just say that every mother has an ultrasound scan, we have to look for methods to increase access to that ultrasound scan. Because if we have home deliveries, they can still be done by midwives at home. But we must have something to make sure that that delivery should happen at home. Doppler ultrasound should be used very minimally because it has come to be known that non-ionizing radiation is very dangerous and hazardous to the fetal cells. So we shouldn't use Doppler unless it is really, really indicated and necessary. So for my comments would have been that as pediatricians and gynecologists, we should use the platform of Beyond Zero and at least have a timetable of where that can go into the rural and collect data on pregnant mothers and make it mandatory for them to have at least, whether they are teenage pregnancies or multiparous pregnancies, they must have a minimum of 1 ultrasound scan. And that will actually reduce our medical bills. Thank you very much for giving me a chance to talk at your symposium.
Thank you very much. Which country are you coming from?
Dr. Wambani Sidika from Kenya.
Kenya. Okay, yeah. Good.
I'm a pediatric radiologist by training.
Thank you very much. Thank you for your inputs. And I think it brings up very pertinent issues that we must begin to address. In the Kenyan system, 1, who is financing these packages for both antenatal and intrapartum and postpartum? We do have the UHC package. The question is it really being made comprehensive? Number 2, out of pocket is still a major issue. Yeah, out of pocket vis-a-vis the demand for services, whether you're giving me a cash transfer or you're giving me a voucher system. Yeah, number 3, we keep repeating this, and I think we need to really begin to scrutinize it further. The quality and comprehensiveness per visit, per woman, whether I come in the first trimester, the second or the third, or I actually appear in labor, and the kind of care that one is subsequently getting. So I think what you're bringing up is really, really key. The last thing I'll mention in what you've mentioned is the issue of having a team approach. A baby is not just pediatrician's headache, nor is it gynecologist or midwife's headache. It should be a twinned headache right from the outset, and particularly where you have high-risk pregnancies, as Dr. Guaco has even mentioned. Now, I will give space for Valentino Lemma. The perinatal outcome in cases of decelerations depends on influence by, among other issues, the cause therefore, i.e. gestational age, duration of deceleration, among other factors. Hence, expeditious determination and action are crucial. He's given a comment, we can't agree more. Are there plans underway, this is for Dr. Soti, to train nurses in the ways of fetal assessment? Dr. Soti?
Yes, Dr. Kihara, sorry. I would answer this in two ways. One, as an institution, institutions should be able to build their capacity, internal capacity, to be able to train nurses within their institutions because they're the ones who spend most of the time with the patients, to be able to interpret CTGs where they are available, and where we have done this successfully, we have had good outcomes. And even the nurses themselves may end up now being TOTs for new interns, medical students, and new staff. The other approach which has worked, and I think Dr. Philomena Wende is here as well, is through the ALSO program. Not a trainer there, but the ALSO program has some training facilities for nurses, so people can be pulled together and trained together on how to interpret CTG. However, what it may miss is the mentorship that continues after that. So it's one of the things that can be used. Yes, but nurses play a greater role in terms of passing on the skill and being able to maintain the skill within their units.
Okay. Somebody was asking, could hypertensive disease be a contributing factor to stillbirths? That one I think has been answered very eloquently by Dr. Guaco. Will I be able to make a comment? She has already commented, but I know Githai also wanted to comment. So Githai, give you 2 seconds to comment.
Oh, 2 seconds, okay. Thanks. I will just very quickly make some comments, if that's okay, a little bit more than the 2 seconds.
Okay.
There are some questions I answered in the Q&A that had been asked. In the answered section, you'll see that. About intrapartum CTG, because Kenya and the region don't do fetal blood sampling, I encourage people to look at physiological CTG interpretation, and there is a link to a guideline that I shared in the chat box. Then the other challenge with Kenya is sepsis and infectious conditions if you're going to do fetal skull pits monitoring. Therefore, that's why I'm talking about physiologic CTG interpretation. There was a comment about cesarean section and stillbirth. My colleagues, Guaco and Soti, did very well. However, I must mention that cesarean section is a risk for future stillbirth. There's a 0.5 per 1,000 risk of getting a stillbirth in a future cesarean section. There was a comment about skilled birth attendants in Kenya. Actually, the statistics globally are showing that Kenya is doing very well in terms of skilled birth attendants. What we should be asking ourselves is, we've brought the women into the facilities. What quality of care are we giving them?
Yes.
I have a few comments on ultrasound. The first one is the issue of giving women scans. The mandatory scans should be between 10 and 13 weeks, where we look at the nucleotranslucency scan, and then another scan at 18 to 22 weeks, where we look at the fetal anomaly scan. So every woman in Kenya, we should be championing for at least 2 scans, 10 to 13, and then fetal anomaly. And then those at risk of, for example, getting a small for gestational age baby are the ones we should offer serious scanning in that trimester. We can choose for 28, 32, and 36 weeks, or 30, 34, and 38 weeks. Or if we don't have the money to offer all those serious scans, at least 1 scan at 36 weeks will do. But the mandatory ones, 10 to 13 and 18 to 22. There was a comment about non-ionizing radiation. This is only applicable in first trimester when heating of fetal cells can occur. In other trimesters, we only expose those pregnancies that are at risk to the Doppler scans. Lastly, 2 comments. We need to standardize the quality and reporting of scans. I'm outside here, but patients still send me their scan reports, and you wonder whether they are making sense, who did them. So as KNH and UoN is where the change goes to the rest of the country when it originates from the two institutions, as well as our professional bodies. Can we have a document? Because we cannot regulate who is doing the scans. Can we have a document on standardization of reporting and the quality of scans? And also get more obstetricians to do scans by promoting fetal medicine. Lastly, Osoti mentioned about nurses and training. I think one way we can sort out this problem is promoting midwifery as a standalone profession, such that when somebody has been employed as a midwife, they cannot be deployed to another area. That will sort out our problems completely. But so long as we are talking of nurses taking care of obstetric patients, they will come, we train them. The next 3 months, you hear somebody has been taken to the medical or surgical ward. So it will sort out our problem of movement of staff. Let's make noise and support midwifery as a standalone profession. That's all I wanted to say. Thank you very much for the 2 seconds.
Thank you, Dr. Gidai. But I'll also add one more thing, workload to workforce. I think that's really the bigger elephant in our house and our houses where we practice. Now, Dr. Osoti, how would you differentiate early fetal growth restriction from late growth restriction in terms of monitoring fetal surveillance, and are the tools different?
Okay, thank you, Dr. Wende. So early onset growth restriction is usually the cutoff is about 32 weeks or so, compared to late, which is above 32 weeks or maybe 37 weeks. The decision is not quite clear, but the cutoff is around 32 weeks or so. Now, the early growth restriction is mainly occurs in the presence of things like early onset preeclampsia. So you should be able to tell that based on the clinical presentation of the patient. Okay, versus a late one, which could also be due to late onset preeclampsia, which you can also tell from the clinical presentation as well. The other way of telling it is from the Doppler studies as well. So you will have early abnormal Doppler studies, of course, in the early onset versus the late onset, which tends to be relatively normal until quite late. Now, the issue is the management, as I said earlier, depends on several factors, because if you have early, you follow them over time, and when you see them tipping over, then you need to intervene as soon as possible. But if you have late, then sometimes the benefit of delivery outweighs the risk of monitoring. So those ones, even though they are likely to have adverse outcomes, but timely delivery would be appropriate. That's my quick answer to it. The other comment I would want to make, Dr. Gidai has talked about, and Dr. Wambani as well talked about, we actually, one of our residents, Dr. Ndinda, looked at the quality of ultrasound and the quality of reporting. You'll be surprised that less than half of the ultrasound request forms had the correct information that was needed for the radiologists to be able to give appropriate reporting. And less than about 2/3 of the ultrasound reporting by international standards were insufficient. So actually the work has been accepted for presentation at the RCOG as an oral presentation. So for those who are going to attend, please attend. It was not accepted locally, but it was accepted in the international conference for presentation. So we are doing poorly, and our recommendation is, as Dr. Gidai has said, that this needs to be nationalized and institutionalized so that we have a standard way of reporting. Thank you.
Thank you very much, Dr. Soti, for re-echoing what Professor Wagnero is saying. Strengthen data or you fail. You're doomed to fail, actually. Now I'll give 2 opportunities. Elizabeth, please summarize the question you've asked. It has a lot of mnemonics in it. Some of it I don't understand. Elizabeth Irongo, unmuted. And Monica Joroge, you will also be given an opportunity immediately after Elizabeth. Then we can address those questions. Elizabeth Irongo, are you there? IT, can you see her?
Yes, I've seen her and given her permission.
Okay, Elizabeth, please ask your question. Oh.
Yes, hello?
Yes, go ahead.
Thank you so much for the opportunity, Dr. Kihara. I was asking, in my opinion, would it be feasible to merge Beyond Zero and Linda Mama? Because the two of them are about maternal health. So if you have two separate programs with the same sphere of influence, it's kind of, in my opinion, it's like splitting hairs. So why not have an incorporation? Because in the PPPs, sometimes if you have a lot of the PPPs, you end up compromising your public health system. So like what they're doing in Ethiopia is reinforcing the public facilities, because if we have both of them running in parallel, for me, it's a bit, I don't know, in my opinion, why not have one? I don't know, it's just my thinking.
Well thought out. In fact, automatically you can see the division of labor, you can see the division of resources, you can see the division even in reporting. And at the end of the day, the customer is one primary customer. So I want to believe with the UHC, if it can work, and having come out of the piloting, is to actually amalgamate, because that's basically what we are looking towards, amalgamating the different policy directions and demand systems that actually are existent. So I agree with you 100%. That should be the way we ought to go. My issue would be, and I think Professor Duarte is still with us, and Professor Pamalwa, in creating the packages that we do create, can we speak together? In other words, can obstetrics piggyback on pediatrics, and can pediatrics piggyback on obstetrics? The siloed issue is still a persistent thorn in the flesh. We all tend to work autonomously as opposed to working together. Monica, unmute Monica Njoroge.
Okay, thank you so much.
Go ahead. You had a comment to make?
No, I was just saying thank you so much for giving me the opportunity to ask, and it's a very interesting discussion for me. Thank you to everybody, the whole team.
Okay, I will give Dr. Dan Okoro an opportunity. Why am I looking at him? UNFPA has been really in a driving seat, looking to have midwifery stand alone. So Dan, Dr. Dan Okoro, can you please give us insights where you have reached, what is going on, and what's the way forward for Kenya?
Thanks a lot, Dr. Kihara, and just generally, and the team for organizing this symposium. Quite informative. I think I followed most of the sessions. Indeed, it is quite an excellent thing to have this. And I do want to support the sentiments given by my friend, Dr. Francis, on the issue of the midwifery. Because by and large, it's about the quality of care. And as many have alluded to, the issue of the transfer, the rotational basis, is quite frustrating in the clinical care or management of our women in the reproductive field. So just a quick one in terms of, many of you should read the State of World Midwifery Report, which highlights some of the challenges faced by the countries so far in terms of the midwifery program. But coming to Kenya, UNFPA is supporting, together with, alongside Johnson & Johnson and other partners, the Ministry of Health, to develop national and nursing and midwifery policy, which we have never had before, and also the training for development of a syllabus for the midwifery training, looking at direct entry right from the KMTC, because right now we know some of the universities are having them, like Aga Khan University is having direct entry at the BSc level. But we really need to know where the bulk is, and this goes alongside the development of the curriculum and the training, because challenge also comes into the issues of the trainers, the tutors or the lecturers. Some of them, some studies have indicated that their capacity is wanting. So these are the challenges that we do face. So while we want to increase the numbers, but even the quality of the training and availability of the facilities is quite crucial. So this is a work in progress, and I believe we'll be inviting COGS and KPA on board as we work on this path. Thank you so much, Dr. Kihara.
Thank you, Dr. Dano Koro, for those insights. Elizabeth Gige, wonderful presentation. Kindly explain why gestational age varies, e.g. scan indicates gestation of 26 weeks, but impression is a gestation of 36 weeks. Dr. Soti.
Thank you, Elizabeth. So for us to be able to correctly establish the gestational age, we want to do the ultrasound as early as possible. So that is why it's very important for you, as Dr. Ambani was mentioning, you need to have at least 2 ultrasounds. So one is for dating, very important, and then another one for fetal anomaly. And if you're not able to get, one early enough, then at least you do, if you're only able to get one, do one at around 20 weeks, where you get the anomalies evaluated, as well as at least some estimate of the gestational age. So the commonest reason why there could be a discrepancy, okay, could be wrong dates, okay, so maybe the patient is just not able to recall correctly their gestational age, or they were using a contraceptive before that interfered with their usual ovulation pattern. Then the other one, which is ominous, is if they, like in the case that you are giving, is a fetal growth restriction, and if that happens, then that requires further evaluation. So whenever there's that discrepancy, we actually recommend that somebody senior who is experienced in the facility, preferably an obstetrician, review, so that you figure out what exactly it could be, whether it's wrong dates or a fetal growth restriction. Thank you.
Last question, last but not least, what normally brings about such cases whereby a mother attends a clinic and the fetal heart is felt during all the visits, but during labor, the heart rate is not felt, but the baby is delivered healthy, but with a low heartbeat? Dr. Soti.
Okay, good question, excellent question. Yeah, so the mother attending all the clinic and the fetal heart rates felt, yes, that's okay, because you can be able to pick the fetal heart rate even if there are other factors like congenital anomalies that may be may affect the life of the baby extrauterine. So getting a fetal heart rate alone is not reassuring. That's why it's very, very important for us to be able to get at least that anomaly scan, because there are many babies who are born with congenital malformations that were not picked during the antenatal period. And even if they had a scan, could have easily been missed as well, because we've also seen that as well. So that's one possibility that could occur. The other possibility is that, as we said, if the mother did not have any risk factors, but then the monitoring was not very good during the intrapartum period and their risk status changed to high risk, okay? And because of various reasons, maybe shortage of staff, lack of equipment, or something else, this baby now is born with what we call birth asphyxia or something like that. Yes, so each situation can be treated differently. It could have been something that was missed during the antenatal period, or because of lack of an ultrasound or proper evaluation, okay? Or it could have been something that happened intrapartum. And that's why we have the essence of this whole talk that we gave, to be able to identify those fetuses who are at risk of intrauterine fetal demise or stillbirths, and those who are likely to get neurological adverse outcomes like birth asphyxia and what you're talking about. Yeah, thank you.
Thank you very much. Now, ladies and gentlemen, we have come to the end of day one, but please don't go away. Tomorrow, we even have more exciting topics. One, I think the main one will be addressing the collaboration and synergism that can be created in addressing perinatal health. We will be looking at communicable diseases, which is one of our burden areas. We will also be looking at the health system tomorrow. And finally, tomorrow again, we'll be looking at the forensics. Today, we looked at the stillbirths in 4 counties. But what is the forensics really telling us? So we look forward to having you with us tomorrow. If you do have any questions you still would wish to have addressed by the panelists that we've had this afternoon, you can always forward them to the KNH link site that I think should be actually displayed. Now, a lot of you have asked whether you have access to these PowerPoint presentations. Once we get consent from the presenters, they will actually be put in the KNH repository. And my prayer is don't reposit and file it. let's reposit and apply it to where we actually work as health providers, giving care to patients, or as consumers, where we can also make a difference for mothers who unfortunately may lose or have babies born too soon, with grappling to how to take care of them the best of our ability. So I'll close today's session. I want to appreciate each one of the presenters. I want to appreciate the rapporteurs, because I'm sure you have a lot that you have in store to share. And I will also want to appreciate my co-moderator, that is Professor Dalton Pamalwa. And I will finally want to appreciate the ICT team and the group from KNH led by Dr. Thank you so much, and God bless each one of you in the evening. Bye.
Thank you, bye.